Good morning. The live stream has started. It was better, a little lower.
Testing 1, 2, test, test. Shannon, can you hear me?
Sounds good.
Gentlemen, ladies and gentlemen, if you'll please take your seats. I will call this meeting of the Oversight Committee to order. It is 8:31 a.m. Mr. Taylor, please proceed with the roll call. Here.
Here.
Present. In living color.
Dr. Patel. Yeah. Dr. Elizabeth. Here.
Thank you. Dr. Rice previously notified CPRIT that he would be unable to attend today's meeting. The chair will entertain a motion to approve an excused absence for Dr. Rice. All in favor, vote aye.
Aye.
Any opposed? Motion carries. Members, you have the draft minutes from the August 20th Oversight Committee meeting in your agenda packet behind tab 1. Are there any corrections to the minutes as circulated? The chair will entertain a motion to approve the minutes of the August 20th Oversight Committee meeting.
So moved.
Second.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Our next agenda item is public comment. Texans created CPRIT. Opening our meetings with public comment underscores this board's commitment to transparency and accountability. Mr. Ellis, has CPRIT received any requests to provide public comment?
No, Madam Chair.
Thank you. Item 6.
Madam Chair, Dr. Shokar will be arriving later, so we can move to the next agenda item.
So we will move to item number 6, the Chief Executive Officer report. Ms. Doyle will provide the Chief Executive Officer's report.
Good morning, members. I will keep this short because we have a big meeting today. $154 million in awards, which will take us past the $4 billion mark in terms of awards that we have made since 2010. So it's a huge milestone. We also have passed now the $1 billion mark in terms of recruitment grants. So these are all really exciting events that have happened. All 3 programs will be presenting today. If the board approves all of the awards, I believe it's 73 awards, we will have about $120 million left for the rest of the fiscal year in terms of awards. It's also an exciting meeting. It's the first for Madam Chair presiding. We also have a new Chief Prevention Officer, Dr. Ruth Rikus. You can go ahead and stand up, Ruth. So we're thrilled to have Ruth with us, and you will have the opportunity. She will present awards. Also, we'll be up here when Dr. Shakar arrives to give the grantee presentation. And now Dr. Hebert is our old hand in terms of program staff. And it's really been wonderful to have these 2 new chiefs. They are coming in with fresh eyes and fresh perspectives, and you'll start hearing about that, even from this meeting going forward, and it is very exciting. And as a benefit of that also, we have talked often, and Dr. Cummings knows this because this was a big initiative of his when he was presiding officer, in terms of going out and visiting our grantees where they are working. So Dee has already worked with us to get a trip in place in February. We'll be going out to El Paso. And so it'll be the program staff, CPRIT staff that will go out and meet with the grantees. And we are looking over calendar year of 2026 to be visiting many of our sites around the state. We'll keep the Oversight Committee members updated on that, and hope if you are available, maybe there'll be an opportunity for you to accompany us to one or more of those sites. They're always fantastic to go and hear the grantees talk about their projects. That's why we try and have the grantees come in and give presentations to the Oversight Committee. You guys have such an awesome responsibility in terms of the millions of dollars that we are committing to these projects, but you always hear about them at the very beginning. When it's kind of the hopes and dreams, this is what we think will happen. To hear what the results are of the things that you have put into place is really, it really affirms what we are doing. And then also to hear the passion of the people that are doing these projects is fantastic. So we'll keep you up to date on that. Also, in terms of 2026, we have some big things coming up. We will have the Innovations Conference, which will be in October. Heidi will talk about that later in this meeting. We also are anticipating an efficiency audit. CPRIT is lucky enough to be one of the first agencies that will undergo this efficiency audit. So we're already, looking through everything. Really, gives us a good opportunity to examine ourselves as we prepare for that. And part of that process is moving our grant management platform. We're excited about what's happening with that. It will be a huge year of transition on that, but it should result in some very good changes and efficiencies for us. I'll end right now talking about, again, it seems like so long ago now, but it's been less than 2 weeks, I guess, of the vote to approve CPRIT. And this is really a fantastic, fantastic milestone for Texas. But it is also really attributable to the work that you do. We talked about it during the legislative session, and I'll say it again. And you've seen all of the work that was done to publicize the vote. In every case, when legislators would talk about it, when the community would talk about it, they would say, this is CPRIT for dementia. And that was the code word of a successful, trusted project, that has proven its worth, which is, especially for those of us who had to go through just getting the legislation passed, in 2007, and then changed in 2009 and in 2013, to have that shorthand of CPRIT as the gold standard really is phenomenal. And again, it is, attributable to the work that you have done, the accountability that you and the integrity that you have committed to and set the bar high. So, I hope that we all, took the opportunity to toast the anniversary of our vote, the 18th anniversary from 2007, and then also the successful passing of CPRIT. So with that, we will move. I don't have anything further, but I am happy to answer any questions.
Are there any questions for Ms. Doyle? Yes, Mr. Montgomery?
No questions. I mean, you're very generous in your praise of the Oversight Committee, but an equal, if not greater amount of praise goes to you and the staff and the predecessor staff. So thank you for all the hard work. Thank you.
Okay, thank you, Ms. Doyle. The chair recognizes Mr. Burgess and Mr. Nance to present the Chief Compliance Officer's report. Which, as you know, is one of our favorite reports.
Glad to hear. Madam Chair, that's got a good ring to it. My report is behind tab 4 in your booklet. Again, we've got quite a exciting meeting, so I'll be brief. You may recall in November of every year, we give you a summary of the previous 3 months, but we also provide kind of a snapshot and a summary of the previous fiscal year activities. So I will just make a comment on the last 3 months, and then I'll pass it over to Mr. Nance to highlight some of our FY 2025 activities. The one thing I wanted to comment on is it's been business as usual the last 2 or 3 months with the compliance team. We've started our on-site reviews for this fiscal year. Things are going full steam ahead. The one thing I want to comment on is you may recall the last couple of meetings, we've talked about our match expenditure reviews and how they've skyrocketed the past few years, and yet the amount of disallowance has gone down. And so we've really sort of asked ourselves, is the juice worth the squeeze on that particular compliance, 100% of all expenditures. So as we had mentioned before, we have implemented a tiered approach to that. And so as a new product development grantee, you'll get 100% review. And based on that, that informs the next year's level of review. So we've implemented that. Any questions on that?
Any questions for Mr. Burgess?
Okay, I'll pass it over to Mr. Nance.
Thank you, Vince. Good morning, Oversight members. As Vince indicated, we're just going to do a quick recap of fiscal year 2025. I'll start on page 4-3. For our delinquent reporting, every year we kind of put together the monthly average for the fiscal year. And for fiscal year 2025, we saw a nice decrease in the number of delinquent reports on a monthly basis, down to 13 from the prior year of 26. So we're very pleased with that. Next, we'll talk about second level reviews. Compliance staff reviewed almost 2,300 second level reviews of those financial status reports in 2025. And then on to the next page for training. CPRIT staff provided 23 grantee trainings this past year. That includes annual compliance trainings, new authorized signing official trainings, as well as new grantee trainings, and including some technical assistance trainings for those new grantees coming on board for their financial status reports to help get them started on the right path. Moving over to page 4-5, compliance monitoring reviews. Staff conducted 67 compliance reviews this past year. 36 of those were enhanced desk reviews and 31 of those were on-site reviews. We've got a couple of charts here just letting you know just kind of the breakdown of those reviews with findings. Just to highlight those really quick, the desk reviews had approximately 55% of their findings were related to timeliness. So that's something that we really try to look at as far as just timeliness of that required reporting. And then with our on-site reviews that were conducted, approximately 73% of the findings were associated with timeliness. So again, just really honing in on making sure that we're trying to do everything as possible to get timeliness taken care of. So we're still monitoring that. And then as Vince talked about with our matching expenditure reviews, so in fiscal year 2025, we conducted 35 annual matching reviews for almost $52 million worth of match expenditures. Of that, we only had a little over $51,000, which was the driver for the tiered approach that we're doing now. And then obviously you can see those the charts associated with that. So just for your information, that's almost a little over a $22 million increase from fiscal year 24 in the amount of match that was reviewed. So that's pretty substantial. That concludes our overview of 2025. Happy to answer any questions if you have them.
I will comment real quickly, if I could, Ms. Payne, that one of the things we implemented a couple of years ago is for product development grantees, once you become a grantee, you have to have a new grantee training, but then also we have been providing technical assistance up through your first FSR submission. And we walk through that process with you. And we find that that's really been successful and has yielded some really positive results. And so we continue to do that to really, because for many companies, this is their first sort of like, foray into public funds. And so I think it's a whole different beast receiving public money. So I think it's been a positive activity for us. So.
Any questions for Mr. Burgess? Yes.
The reductions. No, I'm not going to hit you hard. It is exciting. And I want to extend your talk here as long as possible. But the reductions and everything, what do you attribute all that to? It's very positive and everything else, and it's pretty dramatic in the numbers on that. Is it just simply better educated grant recipients and things like that, or is there a big change, or what? It's better communication.
Dr. Cummings had a great comment. It's all the great work that staff do, and we try. We meet weekly as an agency. Most of the staff are present for this weekly delinquent report meeting, and so we try to keep on tabs as best we can. We're on-site reviews for all of our product development grantees annually. Any prevention and academic research grantee there, every 3 years at least. We also do ad hoc. But from the very beginning, what we've tried to do is say, we want you to be successful, a grantee, and to help cure cancer. We don't want to be a stumbling block or roadblock to that. There's rules to follow. So we're a kinder, gentler compliance. But we really try to look at the issues proactively and say, where do we need to address, and what do we need to in our every year for our annual compliance training, we're tweaking that every year to look. We reach out to program managers to say, what are you seeing as issues for your programs, and we try to tweak our training every year. So, and another thing too, Mr. Margot, is that we have in the last year or so implemented some standardized reporting and forms and formatting, and that has really helped quite a bit too. Of because our grant accountants, it's very complicated for them, right, to have 540 grants at any one time, 60 to 70 unique grantees reporting expenses in 65 different ways. And so we're trying to, how can we kind of standardize this to make it easier to process and just clear for everyone involved. So
we talked, I think, at the last meeting about the number of the increase in grants and your staffing and the need for more staffing. Have you added more staffing?
We added. We did get one new, I believe, Kristen or Heidi, correct me. I think we added one new staff, and this fiscal year.
So you're okay on your staff?
That's a trick question. I think
yes?
we are trying to be as efficient and as effective as we can with the resources that we're given. But Mr. Montgomery, why was that funny? I thought that was a very good answer.
Very elegant.
We needs to be replicated on a frequent basis. Anyway, yeah. Okay, that's all I had.
Thank you, sir.
Yes, Dr. Rosenfeld.
Just a quick question on the last table where it's unallowable match expenses. Could you say a few words about what is an unallowable match expense?
So typically what we're seeing for our unallowable expenses are either things that are just, they wouldn't be allowable on an FSR, unallowable travel, different things, meals maybe. And then the other part that we typically see, or if we see anything, would be something that had been previously claimed on a financial status report already.
Yes, Mr. Montgomery.
Yes, thank you, gentlemen, for excellent presentation and really incredible work. $51,000 is hardly a rounding error for 51 million. But, I just want to remind everyone that a lot of the credibility that Ms. Doyle talked about comes from a very strong compliance department,
Thank you.
right? That we know we can back up. We're following all the rules, which historically, maybe a couple of times did not happen. But I hope that CPRIT will take advantage of the superb compliance program you guys have developed. Are you in touch with them at all, or about, I guess they haven't even staffed it. It's too early. Yeah, sorry. Okay. Well, anyway, it's a great model. Thank you very much.
Thank you, sir.
Any other questions? Okay, thank you. You guys have a big job to do, and you're constantly changing and adapting and helping the grantees. So we appreciate that.
Thank you.
Okay, turning to the certification of the award slates that we will consider today, Mr. Burgess provided the written report certifying that the proposed awards and review process complied with CPRIT's statute and administrative rules. Are there any questions for Mr. Burgess? Thank you. Okay, item number 8. The chair recognizes Dr. Reckes to present the PICS Prevention Award recommendations and to provide the prevention program update. Welcome.
Thank you. Glad to be here. And since I'm on week 7, I'm glad Mr. Allen is here with me as well.
Happy to help.
Thank you so much for this opportunity. We look forward to providing the update from the prevention program. You'll find our materials behind tab 5 and the proposed recommended awards on page 47 in the proposed award book. We'll be talking about 15 recommended awards totaling $27,169,050 across all of those projects. There are 15 proposed projects, and they all 15 are aligned to all of the program priorities for our prevention program. Next slide, please. We wanted to first give you an overview across the 15 recommended awards, just some basic information. So you'll see here across those 15 institutions or 15 recommended awards, there are 8 institutions, one of which is the Young Women's Christian Association of San Antonio, which, if moved forward, would be the first time that they would be an awarded grantee of CPRIT. Can see we received many both expansion and new opportunities and resubmissions as well. And it's just over 50% are expansion ideas building on amazing solid projects that have already been supported by CPRIT in the past, as well as about just under half of them are new ideas and new projects that have come in. So a good mix of both building on successes and bringing in new ideas. Next slide, please. You can see here a summary in blue of the current active grants and the areas that they are focused on. And then in the gray, the new recommended awards and the areas where they would be focused on. And I think this is an important topic since we know there are many areas to address within the prevention program. And so you can see there's a little bit of an evening out across some of the major areas and types of cancer that we see in the state of Texas. Next slide, please. Here's our current look at the geographic locations of where we see residents of people served by CPRIT prevention projects. We currently have projects in all 254 counties across the state of Texas. And in the next slide, you'll see where we would be adding projects. In the last slate, I believe we added several in West Texas, but did not add any in South. And in this round, we're adding projects that would serve 811,508 services across 154 counties, which we are adding many in the South, Central, and East parts of Texas. Then here we wanted to start with a review of the 15 recommended, and we are happy to answer questions about any of the 15 that you'd like to talk about, but just selected 5 to give you a little bit more of an overview of those, which we think are a good representation of all the projects. So wanted to talk a little bit about the third one you'll see here on the slide, Access, Advancing Colorectal Cancer Screening in East and South Texas Services by Dr. Maria Fernandez at the University of Texas Health Science Center at Houston. Dr. Fernandez is a prior recipient of CPRIT funding, but this is a new project. It's a colorectal cancer screening project using evidence-based interventions to reduce colorectal cancer incidence, morbidity, mortality among underserved populations in both East and South Texas, serving a total of 30 counties within this project, but building on an existing program that really focuses on federally qualified health centers Oftentimes in the federally qualified health centers, we see even lower cancer screening rates than we do amongst the average population. And they'll be working to ensure that we are delivering evidence-based interventions that are getting into the clinic workflow of those federally qualified health centers, which has a good potential for long-term sustainability and really helping those clinics to deliver screening services over the long term, even after the funding from CPRIT would be gone. So excited to see that. Dr. Liu's project, the one above that, also focuses with federally qualified health centers and ensuring that they're getting projects into the workflow overall. Next slide, please. On the next slide here, you'll see several different projects. The last two are focused on lung cancer screening and tobacco cessation projects, and wanted to draw your attention to Dr. Zurab's project from Baylor College of Medicine. This is a lung cancer screening program that will expand to new areas in Central and West Texas to increase screening and early detection among rural and urban high-risk patients while maintaining and expanding a comprehensive evidence-based smoking cessation program for individuals. They actually took a look at what parts of Texas needed lung cancer screening the most and are delivering the services specifically in those areas, adding Lubbock as one of their focus areas as well. And that project is actually part of a consortium with all the other lung cancer screening projects that are funded through CPRIT. Since there are not many lung cancer screening projects in Texas, and since we have such a big state, they have all banded together to share their best practices, their lessons learned, and work together. They're currently working on a manuscript to share some of their findings as well. And actually, Dr. Argamright, Dr. Gerber, and Dr. Zurab all participate in that group. But great to see that CPRIT funded grantees coming together. So this project would build on that expertise and bring that program to other areas as well in 12 counties, serving about 78,000 individuals through that project. Next slide, please. On the next slide here, you see 3 wonderful projects, and wanted to call your attention to VITA, Vigilance, Information Detection, and Advocacy from Dr. Serta at the City of Laredo's Health Department. We're excited to see a health department on the slate of applications. They actually received a grant in 2010, but this would be the first grant for City of Laredo Health Department in some time. This is a breast and liver cancer screening project targeting medically underserved, uninsured Hispanic adults using a digital media campaign to raise awareness of breast and hepatitis C virus screening in 3 South Texas counties. One of those counties is Webb County, where we find that it's actually double the state average for liver cancer within that county. And we already have a high rate of liver cancer in Texas as compared to the rest of the state. And so to see that even higher there. So with hepatitis C virus screening, they'd be able to detect those things early and hopefully reduce the risk for liver cancer over the long term. And it's really designed to be mirrored by other health departments and for other communities that might have similar characteristics of the City of Laredo. So again, provide some lessons learned. I'll actually skip ahead 2 slides. Oh, I'm sorry, back 1 slide. So I wanted to call your attention here to the project from the Young Women's Christian Association of San Antonio, from Doorstep to Diagnosis, multi-component community health worker coordinated program for breast and cervical cancer screening in Bexar County. This is a breast and cervical cancer screenings and HPV vaccination project using community health workers to deliver a coordinated multi-component intervention to expand services among underserved women in Bexar County. And this is a project that the Young Women's Christian Association has in practice, so they have some good history of doing it. But with the support, they'd be able to expand it to really have a more mobile program that would go to more of Bexar County, as well as a direct door-to-door project and a larger campaign that would help them to reach more individuals with breast cancer and cervical cancer screening, as well as HPV vaccination, as well as connecting those individuals to a primary care physician. That was something they were excited about in their proposal, was really to make sure people had a place to go for all of the care that they needed. A little bit about that project. Sorry, now we can go ahead 2 slides. So wanted to also draw your attention to one of the primary prevention of cancer projects from Dr. Varela Ramirez from the University of Texas Health Science Center at Houston, boosting breast and colorectal cancer prevention through physical activity, assessment, prescription, and referral into clinical care among communities in need. This is an obesity-associated project. You may have noticed on the previous slide, we have one current obesity-focused project in our active grant. So this would be a second. So we'd be doubling the number of obesity-associated projects that we would be funding through CPRIT, working on modifiable risk factors for both breast and colorectal cancer. So since those are both obesity-associated cancers, and they'll be embedding the physical activity assessment, prescription, and referral core preventive service, a multi-level evidence-based systems-based cancer prevention approach into routine clinical flows at 4 rural clinics in Texas. Again, working with clinics to make sure that that work is getting integrated over the long term. This would help them to really identify those that need to be more physically active and then ensure that they are getting connected to resources within their community and building out a community guide to help make sure people can get access to more physical activity. And those are the summary of the slate we wanted to share with you today, and I'm happy to answer any questions.
Are there any questions for Dr. Reckes or Mr. Allen? Yes, Craig.
Thank you, Ruth, and welcome.
Thank you.
Wonderful slate, and I really appreciate the geographic diversity shown and the fact that all counties are represented. Just had a quick question. As a doctor, one of the most frequent questions I get now from mostly patients' families is, should I get one of those blood tests that generally screens for cancer, colon blood tests to screen for almost every cancer known? And I was just wondering, in your prevention program, have there ever been any applications for using the what's called liquid biopsies or blood draws just to screen for cancer, period?
That's a great question. I don't know if we've ever, I think maybe Carlton, I don't know that we've received any applications for.
We have
for
not
that.
yet. No, I think the science is still, they're still trying to figure out the best way to use those blood screening tests, and we haven't seen them come across our slate yet. But I have a feeling that within the next kind of 5 years, as there's more research done and as there's more science backing it, we will start to see some of those applications. Yeah.
It would be great if CPRIT could lead that expert to get that scientific information to find out if these very expensive tests are worth it or not worth it.
Yeah, absolutely. And I think Dr. Hebert and I are excited to think about opportunities for us to work together across programs as well and see where that prevention research can help to guide our prevention implementation work too. So I think that's an exciting time for us.
Thank you.
Yeah, absolutely.
Dr. Patel?
Thank you, Ruth, and welcome to CPRIT.
Thank you.
You'll have to ignore my esteemed colleagues' opinions, Mr. Montgomery, at times, but just turn a blind eye and an ear to him. Don't worry about that.
Much forward to hear from everyone.
But I would like to ask you 2 questions regarding the initial expansion of tobacco cessation in adults and the maintenance. Approximately, looking at the data now across the United States, approximately 23% of middle schoolers now vape. So that's the data, and that's the target population looking into the future. What, if anything, is being done about that from a CPRIT prevention standpoint of view? That's the first question. And the second is as regards obesity. Again, it's primarily targeted to the adult population that one looks at. But the pediatric population is a significant issue going on, and from a long-term standpoint of view of not just quality of life, diabetes, etc., but that of hepatocellular carcinoma. If you can address those 2 issues, please.
Absolutely. I think that that's a real concern that we're certainly hearing about vaping, as well as we had a conversation in our subcommittee meeting about Zyn and some of those products as well. In my 7 weeks here at CPRIT, Zyn has actually come up several times. Is sort of those nicotine pouches and what does that look like? And the tobacco, how tobacco products and nicotine products are moving forward and having new ways that they're being looked at. I defer to Carlton for if we have projects that are specifically funded, but I will say that the researchers that are are on this slide are doing work both in that pediatric and adult space too. And I think there's, opportunities for more education and spreading that. And some of the researchers, we've been asking questions about this, were sharing with us some different trainings and things that are available, that are widely available within the state too. So I think we can look to opportunities to share through our CPRIT channels as well too, to make sure people are aware of them. I don't know if there's anything you wanted to add in terms of funded projects or anything else.
No, I mean, yeah, I think we would love to see projects focused on that population, and yeah, just like Dr. Recca said, there's been quite a few conversations kind of centered around that. So, we're definitely excited to see, how those talks and conversations kind of turn into applications moving forward.
Yeah.
Would you push towards getting a specific RFA to that effect rather than having it lumped along with the adults? Adults are terribly boring people.
I think that's a great question and something we can take a look at. That's what I'm spending a lot of time right now, is really thinking about where is our funding, where have we been, where are the needs of Texas, where are the biggest areas, and look forward to your thoughts and feedback as we do that process. And as we go, as Kristen was mentioning, as we look around the state of Texas and meet with other people and see where those priorities are and where people look forward to the future. So I think it's a great question. And to your second question, the program I actually just came from and spending the last 9 years at MD Anderson, we did a lot of focus on that childhood obesity space and met a lot of partners in that space. Adults are sometimes it's hard to change adults' behavior. It's hard to change children's behavior. But sometimes once those are cemented as adults, it can be even harder. So I think there's lots of opportunity, and we saw a lot of progress and change over time in our community-based efforts to really work in childhood obesity. And there are many great programs for that space. So again, we'll be looking at that as we look forward into the future and look forward to everyone's feedback about what that might look like and where those opportunities are to really get way ahead of the curve of where those cancer risks are. Yeah, thank you.
Mr. Margot?
We talked about at the committee meeting, and I don't know that you can connect the dots here, but something near and dear to Dr. Cummings over time was the clinical trials and recruiting people, especially in the rural areas. And I just simply asked, is there a way for some of these prevention recipients to connect with potential clinical trial folks? I don't know that the right hand and left hand will know what's going on, but it was just an idea that maybe we ought to think about how can we leverage their contacts with individuals who might be participants in trials. So anyway, I just throw that out.
I think, again, a great question, and I think something we can look to as well. We just did a little bit of analysis of really looking where we have I know where we have institutions, but where we have project directors that are aligned and within the same institutions, or where some opportunities for that might be too. And we have our conference coming up, or later next year. And so where are those opportunities to put forward those ideas and create conversations and think about how people might be working together? So I think it's a great idea and something for us to strive for.
Okay, thank you very much.
Absolutely. I believe we have one more. What do we? Yes, we wanted to review our RFAs for next year as well. My apologies if I'm doing anything out of order. So these are our proposed prevention RFAs for the next cycle. These are the same RFAs as the ones that we have previously had: the primary prevention of cancer, the cancer screening and early detection, and the dissemination of CPRIT-funded cancer control interventions. So primary prevention of cancer focuses on some of those areas that we were just talking about, supporting projects that will deliver multi-level evidence-based interventions that improve cancer-related health behaviors in a wide variety of areas. Cancer screening and early detection specifically focuses on those evidence-based clinical screenings and cancer screening for breast, cervical, colorectal, liver, and lung cancer, according to those established guidelines. And then the last is the dissemination of CPRIT-funded cancer control interventions. And those are specifically on projects that facilitate existing projects and putting them into a form or format that could then be used by others in the state to expand on those programs as well. And that is our recommended slate for the next round.
Any questions on the RFAs? Okay, thank you.
Thank you. Sorry.
Oh, you're perfectly fine. Thank you. Okay, Mr. Burgess has certified compliance for the prevention award process. It is my understanding that no Oversight Committee member reported a conflict with any of the proposed awards. Members, you have the list of applications and grant amounts recommended by the PIC for the Prevention Grant Awards. We will approve the PIC's recommendation if 2/3 of the Oversight Committee members present and voting agree. There are 2 prevention award slates constituting 15 grant recommendations. Rather than taking a separate vote on each grant mechanism, I will ask for a vote to approve all the slates. If a member wants to consider one or more award recommendations separately from the vote on all the slates, please make a motion to do so now. I will entertain a motion to approve the PIC's 15 recommendations for the following prevention grant award mechanisms: cancer screening and early detection, primary prevention of cancer.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Hearing approval from at least 2/3 of the members present and voting, the motion carries. I will entertain a motion delegating contract negotiation authority to the CEO and CPRIT staff and to authorize the CEO to sign the contracts on behalf of CPRIT.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. I will entertain a motion to approve the fiscal year 2027 requests for applications that Dr. Rekas presented today.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Congratulations.
Thank you.
Okay, item number 9. The chair recognizes Dr. Hebert to introduce the Program Integration Committee's grant award recommendations. He will also provide the academic research program update and a request for approval of fiscal year 2026 and fiscal year 2027 requests for applications.
Thank you. It's a pleasure to be here this morning. It's nice to be introduced as the old veteran. Day 110. So it's fantastic. We are looking forward and really excited about the grants and the programs that we have for fiscal year 26. I'm going to introduce those to you, and we can go ahead and start with the first slide if you'd like. The challenge that we have found is that we are exactly 5 years out from the pandemic. And looking back 5 years, we recognize that CPRIT, the staff, the Oversight Committee was brilliant in how they handled CPRIT funds during the pandemic. Went back, you look, and you funded a large number of research training awards, as well as core facility awards that really created a lot of momentum, kept the momentum going for the Texas academic institutions during this difficult time. Brilliant. Our challenge is that we'd love to continue that momentum. And we have all of these awards that are now up for renewal. And so the question is, how do we do this? And so it's going to be a challenge. And so we're going to try and do everything we can. It means we won't be able to fund everything. We're going to have to cut some. We'll also have to reduce the size of some of these awards to try and fund more of them. We may also have to cut the length of some of these awards. And that's just in our funding structure to fund as many as we can and keep this momentum that was started 5 years ago. So congratulations. You did a fantastic job. These are really fantastic programs. And it's really been fun for me to look back historically and see this. But it does create a challenge for us this year. So we're going to meet the challenge. So the first slide shows the Program Integration Committee's recommendations across the different RFAs. Really pleased to bring you nearly $60 million worth of grants. And the next slide will show you that these touch all of our priorities in a really a significant way. Nearly $3 million, at least $3 million really on every priority. So really pleased with this. And we can go on to the next slide then. And as I mentioned, we're going to have to reduce the number of grants that we fund. The Scientific Review Council recommended 32 of the individual investigator research awards. which would be almost $29 million. And we just can't fund all of those. So we want to defer a few of those. The PIC deferred a few of those. We're recommending funding 28 at this time, totaling just over $25 million. And I'll go through some of these grants just to highlight them. I'd love to go through them all, but there's a large number, so we're not going to do that. But I think it's fun to look at some of these. And in terms of, and I really want to go through and highlight some of the specific RFA grants. And for children and adolescents, I'll just highlight the top grant, the highest scoring application. One of those really important studies to do in children with pediatric brain tumors, comparing proton therapy versus sort of old style external beam radiation. And does the proton therapy really improve survivorship, cognitive function? And I think this is a really important study. And we now have 10 or 12 years worth of data. And there's really a great repository. So we can actually answer these questions. I think the other one that I'd like to highlight is an unusual fusion protein, chromosomal translocation. A study comes out of Texas A&M that focuses on this transcription factor, and it should be a really good target in this renal cell carcinoma. It's a really unusual study, and it's one of those rare cancers that, you know, if CPRIT doesn't fund it, no one will. So I think another really important study. The next slide then touches on the computational systems biology. And these are mostly machine learning, artificial intelligence applications. I'll just highlight the one in the middle that's focused on triple negative breast cancer. It's adding in immune therapy to chemotherapy and then trying to predict what patients will really respond well. If a patient actually can reach a pathological CR, a complete remission, then that's a really good prognostic indicator, but it's only going to happen in 10% of the cases. And the question is, can you use artificial intelligence to predict those and then get them onto a different, those who wouldn't make it, get them onto a more aggressive therapy. So a really important study. So the next slide then touches on the clinical trials RFA. And here, immune therapy is the model here for the day. Lots of immune therapy, adding on antibody therapy, other things. But I want to highlight the application in the middle that's using circulating tumor DNA to look at for minimal residual disease, to look for those rare cells that remain that are going to cause the relapse. And can we actually identify those using a simple blood test and then go after and target those and eliminate them? And this gets a little bit to Dr. Rosenfeld's question previously. We do have these blood tests, and so how do we use them? And if we actually find a tumor, what do we do with the information? And in this case, we know what to do. We're going to go aggressively after those tumor cells because we know they're tumor cells and not just a precancer. So an important study. Next slide, please. So in terms of prevention and early detection, I really want to highlight the application here in the middle. This is one where we know that firefighters are exposed to a lot of carcinogens and the smoke and the burnt materials. And the question is, can we protect them from a lifelong risk of cancer? And, what steps can we take? And this is, I think, a really important application that we can all appreciate the impact of that for our firefighters. So really want to highlight that application. Then the next slide, please. So now I want to move on to the establishment or to the recruitment awards. And this is where we're having to reduce the size of these awards. We've looked across the amounts of all of our applications, and we're going to try and reduce the amounts of those largest awards that affect the fewest number of people. So the goal is just to keep the funding to the maximum number of people as high as possible. Dr. Quackenbush is a fantastic investigator. He is one of the world's leaders in genomics and computational systems biology, and he is the chair of the Department of Biostatistics at the School of Public Health at Harvard. And we have the opportunity to bring him to Texas, to Baylor College of Medicine. Member of the National Academy, fantastic investigator. We're going to, as you'll see later, we're going to recommend reducing these established investigator awards, the CPRIT contribution, to $4 million to make, it's these sacrifices that we're going to have to make. But because of Dr. Quackenbush's status and his needs for bringing his team here, we're going to recommend his funding to be at $5 million. And I think this is very appropriate. And he's just a fantastic investigator. It's going to be a real coup if we're able to bring him to Texas, steal him from Harvard. So I think this is fantastic. We also have 2 rising stars, and that's shown on the next slide. Both of these are sort of computational biologists. Dr. Asangani is a leader in the analysis of androgen receptor and how it controls gene expression. And he thinks he's identified a second level of therapeutic target in this gene or protein called NSD2. Really exciting work coming from the University of Pennsylvania studying prostate cancer. So this is fantastic. The second applicant is Dr. Shah. He's actually was trained at Baylor, went off to Oregon Health Science University. He's done a fantastic job. He's looking at the spatial transcriptomics, so the gene expression across the tumor and integrating that DNA. And he's really a computational scientist. And he's going to be a great addition to our computational center at UT Austin. So really fantastic. And then the last recruit is Dr. Elijah Mina, and he's coming from Harvard. He's a first-time faculty award, and he's already has a national reputation for designing genome-wide screens, specifically looking for how proteins are destroyed. So protein turnover, and really exciting work. And he would be coming to UT Southwestern. So really fantastic. And that's our slate. So next slide. Do we need to vote on the slate, or would you like me to continue? Fantastic. All right. So I wanted to propose some changes to these recruitment awards. Again, not something we'd love to do is to reduce the size of these awards, but I think they were designed to really go and extract people from places where they didn't want to move from necessarily. And so we've really done a deep analysis. We've talked to our scientific review committee about what's the appropriate size. And we think that we can reduce the established investigator award from $6 million to $4 million, still provide plenty of funds for a robust initiation of their laboratories here in Texas. So we don't think it's going to really affect the science and the strength of the science. But we might actually have to then rely on the institutions to kick in a little bit more money. So that's sort of the thought here. It's trying to leverage some of the strengths of our institutions in that regard. And so it's really is going to then allow us to fund more recruitment awards, more research training awards, and more of the individual awards. The second change that we'd like to start is to impose a July 15 deadline for the acceptance of these recruitment awards. And this is just to allow us to repurpose funds if we get declines. It gives us a month to bring those back to you and to then take some of the applications that we've had to defer and fund those at the August meeting. If that makes sense. So we understand that in some cases, perhaps the person needs more time. And we would suggest in those cases, we just ask the institution to renominate the person in the next fiscal year. And that means that we don't lose those funds. Does that make sense? So it's a small change, but it's, and I think that currently we ask them to give us a decision within 60 days. And this is going to be about 60 days from the May meeting. So it's not really a big change, but we'd really like to be able to maximize the use of the funds that we have in each fiscal year. And this is a little bit of a tweak to the system to do that. All right, so that's the proposed changes. We also have a list of the proposed RFAs. We're not going to change those. We really haven't had a big deep dive in terms of our cycle 1 RFAs, but for cycle 2, which we'll come back to you in February, we're going to have a number of new RFAs, and so we're really excited about that. But we're going to keep these from the fiscal year 26. We think these RFAs are really solid, and we'd really like to continue these almost every year. So these are great. So the next slide just shows a couple more, and then the last slide, I just want to point out that we want to continue the early onset cancers. We didn't have any early onset cancer applications recommended. We had 12 submitted, but none of those were recommended for funding. And we think that we just need to give the investigators more time to refine their applications, do some resubmissions, and we suspect we'll get some great applications next year. And then just to touch on the research priorities, we're not going to change these as well. We think these are really solid. There's really not much to add to this, but I do want to just emphasize the top research program priority, the recruitment of outstanding cancer researchers to Texas. And I just want to emphasize that's not just faculty. It's graduate students and it's postdocs. And so we're going to put a big emphasis on research training awards. And we think that we really would like to see research training awards be funded across Texas, because we think there's some fantastic students and postdocs all across Texas, and it's really going to bring the science across Texas up to and really help everyone across Texas. So we're really excited by that. And with that, I'll stop and take any questions.
Are there any questions for Dr. Hebert?
Okay.
Yes, Dr. Hernandez.
Morning.
Good morning.
Organized presentation. We have an accountant with us. So that savings that you're essentially going to be making on the recruitment from 6 to 4 and vice versa, we're still spending the money, but now we're going to spread it out.
That's correct.
Instead of us continuing that bucket of money in the same way we're spending it, we still have a lot of needs in Beaumont and Midland, Odessa, and El Paso, all those areas that really, although we tried, we're not making, in my opinion, we're not making the headway that we should be. And why couldn't we consider us essentially earmarking that funds for, if we can't recruit, then we want to use it for clinical trials. We want to do it in those areas, because regardless, we're going to spend it. But that way, there's always a constant revenue stream to those areas to finally stimulate some sort of growth, because they clearly need much more love, so to speak, than say the established MSAs, right? So I would, I don't know if Chairman or anybody in the board consider that, but I would rather allocate that than have it spend the same way to those areas.
Yes, and
upfront.
and to that point, we're going to have a presentation from our advisory committee, from the Geographic Diversity Committee, and I think you'll hear a similar theme from her, and I think for the 27.2 that we'll be bringing to you for the RFAs, we want to establish a series of stable, ongoing RFAs that will be focused more on the Texas Regional Centers of Excellence. And these will include training awards, core facility awards, and then also pilot awards. Because I totally agree with you. We need to get, and the reason I want to run these every year is so institutions can plan. They know that these are going to be there. And so they can plan their hiring and their construction plans, knowing that there'll be a stable source of funds. It's going to be tough. It's still going to be very competitive, but they can make plans even out 4 and 5 years, knowing that there will be a research training award that's designated for those areas. If that makes sense.
Okay.
Yeah. So that's 27.2.
Mr. Margot?
We did the TREG grants for those areas that Dr. Hernandez is talking about. And they continue to need to be better educated on how they can follow on, because I don't think they're doing as much as they should. My question is on the early onset. You said you had 12 and none were funded. Why? What was the big issue on the early onset? Because I would think that would be a major area to fund.
I think there are whenever you have a grant not get funded, there are two sides of it. One, the reviewers probably need a little bit of education, as well as the writers. And so they have to refine because we're talking about applications that are in the top 8 percentile that we're funding, right? These are the best of the best. And reviewers will make mistakes as well. So I don't want to just say it's the investigators in the writing, but this is a hard problem because we don't know the cause of the early onset. And so naturally, the applications don't have as much preliminary data, and their hypotheses aren't as razor sharp as some of the studies in, say, breast cancer or colon cancer. And so the reviewers will tend to want to take those where you get it very clear and you can see the impact, and it's low risk, high impact. That's what all reviewers want, right? Low risk, high impact. So the risk is a little higher on those. And so I think we just have to keep it going, get those resubmissions in it, and then we'll see some getting funded. But it's a very hard problem because we really don't know why it's happening.
Yes, Dr. Cummings.
Thank you so much for your presentation. Enjoyed that. So excited about the breadth of what we're getting this cycle. I want to go back to what you're saying about decreasing from 6 to 4. And I understand the concept of wanting to continue to fund as many as we can that are worthy, that are going to bring the best science. But the cost of relocation, the cost of moving a lab, the cost of moving someone's life work is going up. It's not going down. So are we sure that there doesn't need to be some kind of contingency if we stumbled upon the next Jim Allison or the next person that's going to change the face of cancer treatment, that we have that cushion to make sure that we don't underprice ourselves out of someone great? And I mean, this is all what ifs, I don't know if that person exists this year or not, but I'm worried that sometimes less isn't more.
Yes, I totally agree with those thoughts. And I hope that I hope that we get that opportunity. And I think if we do, then I think that we'll probably bring that person back to the Oversight Committee and ask for an exception. But I'm not quite sure. I know it's been done in the past. I'm not quite sure how it was done in the past. So this is part of me being new, but I know that we have had very large awards in the past, like Dr. Allison, and but I'm not quite sure how that was done, because it seems like that award was probably unusually high. So
just thought. Thank you.
I totally agree with that, but I think as well that I hope that the institutions would have the flexibility to kick in the more money. That's what the thought is here.
And that given the climate of what we're dealing with right now with research funding is a large unknown, right?
Yeah.
And if there may be a squeeze on that is unanticipated.
Yeah, there are no perfect ways of going forward with this. So we're cutting everything in some way. But I would just add one more thing. I think that over the last 16 years, I think I counted this correctly, we funded 235 recruitments of first-time faculty members.
Mm-hmm. Right.
They are now established investigators.
Right.
So probably we don't need as many established investigators, but we may need that one superstar. Yeah. And so I do appreciate that we might want to have the flexibility.
I'm just asking for open minds.
I totally agree with that. Yeah, absolutely.
That we have the flexibility to act when we need to.
Yes. Yeah, I totally agree with that. So,
Mr. Montgomery?
Thank you, Dr. Hebert. Following up on Dr. Cummings' point out that, or make the point that you made in the subcommittee meeting, that in many cases, the $6 million we grant is not spent, right? That And second thing is, can you explain what the deferral means? We had 32 grants approved, only 28 funded. What does it mean for those 4 to be deferred?
Yeah, so it means the Program Integration Committee looked at the budget. We wanted to have some restraint. We wanted to have some discipline because we'd really only budgeted about $60 million for this cycle. And so we deferred those 4 applications at the Program Integration Committee. That means that in August, or really perhaps even in May, if we saw that we're actually ahead of a budget, probably in August, we will then bring those back to the Program Integration Committee and ask them for approval of those grants, and then we bring those forward to you in August. So it's a way that we don't have to go through the entire peer review process again, because those have been peer reviewed. They were recommended for funding. We just didn't have enough money for them. Yeah.
Dr. Rosenfeld?
Thank you, Scott. Had a question on the matching funds that academic institutions provide. And my understanding is that formula is based on indirect costs from the NCI. And as you know, the indirect cost from the NCI is in flux. And I was wondering if you could give us an update on how that stands and how that would affect CPRIT providing academic awards.
Yeah, it's a great question. Because if the amount of indirects are reduced from the federal government, then the institutions will actually have to kick in more money to do the match. So we currently allow them to count the indirect cost rate. I haven't heard much in terms of the federal situation in terms of it being reduced. That sort of discussion is sort of taken a back seat. Of course, the government was shut down for a long period of time. And so we just haven't heard that come up very much recently. So I'm actually optimistic that that's not going to happen. Because what that would do is that it would force the investigators to put more direct costs into their actual grant application, which would mean that the reviewers would actually have to be cognizant of the differences in cost of rent in Boston versus New York versus Austin. And we're asking a lot of the reviewers who are scientists, they're not economists. And so I'm hopeful that they'll still allow the NIH to negotiate those budgets, those indirect cost rates individually with the institutions, and that won't change a lot. But it's very possible that it'll go down. But I don't think anyone thinks it's going to go down to 15%. That's really not realistic. I think perhaps it would go down to 40%. And but then the institutions will still have to make up some of that, and that would be a tough thing for them to do. So it's just going to be one of those things we'll have to monitor.
Dr. Patel?
Scott, thank you. And we've discussed this before. As computational biology is coming from preclinical to clinical, and is the use of artificial intelligence for patient selection of research subjects. Have we thought about the ethical use of artificial intelligence from CPRIT standpoint of view, and what your thoughts are on that?
Yes, I think the critical thing with using artificial intelligence in the clinic is that the methodology and how the AI got to the result has to be clear and transparent. It can't be a black box. So it has to be discoverable and it has to be understandable. Otherwise, it's really just not useful, right? No clinician is going to trust something that they don't understand where it came from. Why would you? It's your reputation. It's someone's life. You just can't do that. So that has to be the standard. And it just has to be very clear, and you have to be able to work backwards and say, okay, this is how it got to that result. And if you can't do that, you can't use it. So I think that has to be our standard for how we move forward. If that makes sense. Yeah. And if any of the other physicians have thoughts on that, I'd really appreciate hearing that as well. But
I just want to make sure that when we do have research subjects involved, and the use of artificial intelligence. That, from our perspective, we should make sure it's fair, transparent, and applied equally. And that is it possible for it to be reviewed in CPRIT when such applications come with those criteria, which have been very well set up now, that we check off those boxes?
I think that's a great point, and we're in the process of reviewing our reviewer handbook, and we'll add artificial intelligence to that. I think that's a great idea. Thank you very much for that suggestion.
Any other questions for Dr. Hebert? Okay, thank you. Mr. Burgess has certified compliance for the academic research award process. It is my understanding that no Oversight Committee member reported a conflict with any of the proposed awards. Members, you have the list of applications and grant amounts recommended by the PIC for the Academic Research Grant Awards. We will approve the PIC's recommendation if 2/3 of the Oversight Committee members present and voting agree. There are 8 academic research award slates constituting 49 grant recommendations. Rather than taking a separate vote on each grant mechanism, I will ask for a vote to approve all the slates. If a member wants to consider one or more award recommendations separately from the vote on all the slates, please make a motion to do so now. I will entertain a motion to approve the PIC's 49 recommendations for the following academic research grant award mechanisms: Individual Investigator Research Awards, Individual Investigator Research Awards for Cancer in Children and Adolescents, Individual Investigator Research Awards for Computational and Systems Biology of Cancer, Individual Investigator Research Awards for Clinical Trials, Individual Investigator Research Awards for Prevention and Early Detection, Recruitment of Established Investigators, Recruitment of First-Time Tenure-Track Faculty Members, and Recruitment of Rising Stars.
So moved.
Second.
All in favor vote aye.
Aye.
Any opposed? Hearing approval from at least 2/3 of the members present and voting, the motion carries. I will entertain a motion delegating contract negotiation authority to the CEO and CPRIT staff and to authorize the CEO to sign the contracts on behalf of CPRIT.
So moved.
All in favor vote aye.
Aye.
Any opposed? Motion carries. Members, closing out our action items for the academic research program, I will entertain a motion approving the proposed fiscal year 2026 and fiscal year 2027 requests for applications as presented by Dr. Hebert.
So moved.
Second.
All in favor vote aye.
Aye.
Any opposed? Motion carries. Thank you. Okay, item number 10. Moving on to agenda item 10, the chair recognized Dr. Ken Smith, whose birthday is today, to provide the Chief Product Development Officer's report. Happy birthday, Dr. Smith.
Oh, to be young again. Good morning. Hey, Tommy, you see my new jacket? Yeah? I'm going to leave it in Kristen's office. She'll be here the next time we have a meeting. Yeah, actually, we'll talk about it later. Yeah, first slide. Thanks. So last we met, I think a good portion of this was known right before these 23 full applications. We had 164 preliminary applications for $1.1 billion. And so we winnowed those down to 24 and we got 23 full applications, but that still was almost $200 million. And so that was winnowed down through our full application process to 14 that went to due diligence at still $136 million. And clearly that's in excess of the $75 million that we have to dispense. So basically what the PDRC did is they took those 14 applications, it was rank ordered based on the peer review, and 9 companies were selected for funding. 5 other companies were going to hold and deferral, take no action on them in case something untoward happens. But at this point in time here today, we're trying to recommend 9 companies at $67 million. The 9 companies that actually asked for 74 million, and I was able to negotiate down about 10% to 67 million, which leaves about 7 to 8 million for the supplemental awards, which are going to be part of the 26-2 cycle, and we'll have to approve that today. That supplemental application RFA will probably be very similar to the one that we did last year. So, next slide, please. This is the slate of all the companies, the 9 companies that are being recommended for awards today. And because it is my birthday and I have so limited memory anymore, I'm going to read to you the 9 companies, a little excerpt for each of them. So bear with me. So the first company is Iterion. Iterion Therapeutics is a clinical stage biopharma company in Houston developing tegoprubart, a potent first-in-class inhibitor of transducin beta-like protein 1. Tegoprubart is being evaluated in an ongoing phase 1b/2 clinical study in patients with advanced hepatocellular carcinoma after exhibiting safety, pharmacodynamic, and clinical activity in the completed phase 1 trial in progressive unresected desmoid tumors. Iterion will use the CPRIT funds for an ongoing clinical trial with tegoprubart with or without a tyrosine kinase inhibitor in patients with beta-catenin activated mutations that have failed IL therapy. Data from this study will guide the design of a registrational study to support tegoprubart approval in advanced HCC. Second company is Air Surgical. Air Surgical is a San Diego-based company developing a small robotic arm that operates inside a CT scanner and provides automated safe procedure plans with the ability to place the needle within 4 millimeters of the tumor. Patients who need lung biopsy face 2 options: hand-guided guess and check needle placement through the chest with a high pneumothorax rate, or airway-based approaches unable to reach most tumors. Nearly 46% require a second biopsy and multiple needles, risking collapsed lungs and delayed treatment of 3 to 6 months. Air Surgical's solution, a small robotic arm that operates inside the CT scanner, providing automated safe procedure plans with the ability to place the needle within 4 millimeters of the tumor. CPRIT support will enable the completion of this robotic system developed with AI path planning software and prove safety and accuracy in the advanced lung models, providing FDA-ready data. Third company is Exo Discovery. Exo Discovery is a Cedar Park, Texas. I guess that's right outside of here. It's developing Exo Discovery Monitor, EDM, a novel blood test designed to improve detection and monitoring of non-small cell lung cancer. EDM is more accurate, faster, and less expensive. The CPRIT grant will enable Exo Discovery to expand the capacity and throughput of the clinical utility of Exo Discovery Monitor test by expanding biomarker coverage for non-small cell lung cancer, and validate the Exo Discovery Monitor test in clinical settings and prepare for regulatory submissions. Empiri is a Houston-based company that is developing eSlice, a proprietary next-generation 3D tumor slice culturing method, which accurately mirrors patient response to anti-cancer drugs. For most cancer patients, many viable FDA-approved options exist, but clinicians must select a treatment for each patient without knowing how effective it may be. eSlice provides information as to why some patients respond to a drug while others do not. The eSlice system retains the integrity of a tumor tissue, which has been validated at a single-cell level. The CPRIT grant will be used to measure immunotherapy responses from patient samples, analyze responder and non-responder eSlice, and address workflow quality control. Crossbridge Bio is a Houston-based company and a prior CPRIT grant recipient that is developing advanced antibody drug conjugates targeting various cancers such as breast, lung, ovarian, and bladder. Crossbridge Bio is creating a new cancer therapy called CBB-120, which delivers cancer-killing drugs to tumors in a targeted way. Unlike older ADCs, which sometimes lose the drug too early or cause severe side effects, CBB-120 maintains the drug stability until it reaches the cancer cells. Crossbridge Bio is seeking to complete safety testing, manufacturing, and initiate human clinical trials by 2026. Immunogenesis is a Houston-based company which is developing IMGS-001, which is a PD-L1, PD-L2 dual specific cytotoxic antibody
for treatment of advanced colorectal, ovarian, triple negative breast, nasopharyngeal, and gastric esophageal cancers. Cold immune excluded cancers like ovarian and most colorectal, normal drugs don't work. IMGS represents a new approach as it co-targets PD-L1 and PD-L2 on immune suppressive cells and tumor cells, blocking their ability to silence T cells. In an ongoing phase 1 clinical trial, IMGS-001 has shown tolerability and early signs of both working for cold tumors and helping patients who have already failed one of the existing anti-PD-1 drugs. If funded, Immunogenesis will complete a phase 1b clinical trial for IMGS-001 to evaluate the safety and clinical efficacy of the drug, evaluate biomarkers of IMGS-001, and optimize manufacturing process. Diakonos Oncology Incorporated is a Houston-based company which is developing DOC 1021, a first-in-class personalized cell-based vaccine to treat people whose melanoma has stopped responding to initial therapy. Refractory melanoma remains a major unmet need despite recent immunological advances. DOC 1021 is a revolutionary autologous dendritic cell therapy for treatment of aggressive cancers. Unlike traditional DC therapies, DOC 1021 employs homologous antigenic double loading that provides a powerful pathogen-associated molecular pattern signal, producing tumor-homing cytolytic memory T cells. CPRIT funding will enable Diakonos to evaluate safety, tolerability, and initial activity of DOC 1021 in refractory melanoma, assess clinical activity of DOC 1021 in refractory melanoma, and correlate immunological biomarkers and clinical outcomes. Next to last is OncoMagnetics. OncoMagnetics is a Houston-based company in developing a wearable, non-invasive medical device to treat glioblastoma. Most therapies fail as they are invasive and or localized and not address how glioblastoma aggressively spreads. OncoMagnetics device, invented at Houston Methodist, has no harmful side effects and is worn for 4 to 6 hours a day at home. Low-intensity rotating magnetic fields target cancer cells by disrupting metabolism and causing GBM tumor cell death while sparing healthy and surrounding tissue. CPRIT funds will help complete FDA the required safety testing, optimize device comfort and usability, and launch formal U.S. clinical studies. And finally, Novascan. Novascan is a Chicago-based company which has developed Margin Scan, a compact AI-enhanced device that is used bioelectrical impedance spectroscopy to rapidly detect cancer at the surgical margin without freezing or destroying tissue. Accurate margin assessment during cancer surgery is critical to fully removing tumors and reducing the risk of recurrence. The current standard frozen section analysis can take up to 30 minutes, requires a pathologist, and prolonged surgery, and may damage tissue needed for further testing. Novascan will expand Margin Scan to breast conserving surgery, where over 20% of the patients currently require additional surgery due to missed cancer at the margin. Building on existing breast data, the project will include algorithm refinement, a pivotal clinical trial, and FDA submission. And those are the 9 companies.
And where are the San Diego and Chicago firms going to relocate?
I don't know at this point in time. It just said Texas in the applications. Probably, I mean, unfortunately, probably Houston or Dallas.
Yes, Mr. Montgomery.
Are we operating on a sort of a standard royalty arrangement with all these companies? Is there anything unusual in whatever we get for these investments?
Yeah, so we have what's called an attachment D, and attachment D outlines what the remuneration to CPRIT is. It's standard, but we've started to negotiate a little bit. So on the margins, one things we'll negotiate, like there's a little bit of difference of obviously the margins from pharmaceuticals, therapeutics, and device and diagnostics. So sometimes the royalty rate might be a little bit lower for device and diagnostics. The fold return might be a little less, but this is something that we've been going on internally, and I've talked to almost probably all of you individually about, and certainly legislators interested in return. And so these things are somewhat negotiable. We also have a royalty on the back end, 0.5%, that goes on in perpetuity. But we try, and in certain cases we've taken equity too. So we're flexible to a certain extent. So it's not standardized, different. Well, I won't say different for every contract. Like I said, attachment D basically is kind of our standard contract, but we'll negotiate from that depending on the situation. But I would say most of them are still under attachment D as a standard kind of form.
I'll add, and I should have included this as part of my look ahead for calendar year 2026. We will plan on having I can never say the word retreat without doing finger quotes around it, because of course, a retreat for a state board is still an open meeting. So don't envision, beautiful places. We'll be in another room like this. And we'll focus, yes, maybe we'll be able to find more comfortable chairs. We'll focus on probably 2, possibly 3 issues, but one of those issues will be our revenue sharing standards. We do have standard terms that are included in the attachment Ds, and though that does include with devices and diagnostics, many years ago, we recommended and the Oversight Committee approved a change. They pay royalties to us up to 2.5 times the amount of the grant. For therapeutics that have bigger margins, they pay us royalties up to 4 times the amount. And then there's a 0.5% royalty tail. That's been an issue also that has come up with on the margins in terms of we've had some companies that have wanted to negotiate with us to get rid of that royalty tail. Can they increase the number instead of 4x? Can it be 6x or 8x? And so we will entertain those discussions. And if it is in the interest of CPRIT, we will do that. But attachment D is the contract that they have. So most are following our standard terms that you guys have seen and known. We will talk about, whether we need to update or change those at a retreat. And going back again, I should have said this in the beginning, the earliest that we would be looking at in terms of retreat would probably be the February meeting. We've talked about, in terms of timing for retreats, doing it the day before an Oversight Committee meeting, the afternoon before. Most of you travel into Austin for those meetings, the day before, so that hopefully won't present a huge schedule change for you. And so, February should be a relatively quiet meeting. Obviously, we're making a lot of awards at the November meeting, so it will give us a good time to focus on that. So that would be the earliest that we would do it. We'd work through the special issues subcommittee with to help establish that agenda, and then make sure that we are briefing all of the Oversight Committee members ahead of time so that when we have this retreat, you come prepared and ready with how you want to propose changes rather than just starting the conversation at the beginning of a retreat.
Dr. Rosenfeld?
Yeah, I was actually going to bring up the standard contract also. And I'm not going to say anything that's new or revolutionary or that you haven't heard before. But the standard terms have been set for quite some time. And I think it's a good time to review them in detail. Just to comment on 2 things. As far as royalties go, if you start to think about a company selling, being bought out by a pharma or something, it's, and there's royalties, say like from the university and from second round funders, you get this complication of stacking royalties, and pretty soon there's no money left for anybody. And so, maybe we should reconsider our royalty only terms. And the second thing with royalties, it kind of means CPRIT is the last money out. And and maybe that's not what we want to do anymore. And I realize how we got here, but maybe it's time to think about more of an equity play. And I know we've done that before on occasion, but maybe it's time to think about that as a more of standard terms.
And we'll talk about this more. I will say in terms of the royalty issue first, when we adopted these standard terms, of course, the Oversight Committee is very concerned about, we don't want to do anything with our contract that would make future investors be unwilling to invest, potential future investors to be unwilling to invest. We don't want to be the poison pill, because as important as our money is, especially right now in terms of bridging that valley of death, we are a drop in the bucket in terms of the total amount of money that's necessary to bring that drug to market. So if we have put some provision into our contract that would make people not invest later, then we've all failed. That drug won't make it to market. So we do have royalty stacking provisions in our contract. We also have the ability to negotiate other provisions, and we have used that to take equity. I will say equity always seems like, well, why don't you guys do equity? And we've even had companies that have proposed that to us. CPRIT's in a unique position, and we'll talk about this more, but we are not like venture funders that can just pull out our checkbook and write another check to avoid dilution in the next series round. Because our statute sets us up to only fund what is recommended by peer reviewers, and we do it on a cycle, that cycle does not necessarily coincide with when you would be making your next round of investments. And we have never used and never been directed by the statute to use financial incentive as the reason to approve a grant. If we did that, we'd probably be doing, putting our money in end stage phase 3 investments, phase 3 clinical trials, rather than, preclinical and phase 1 clinical trials. So we could direct review committees to focus on only the things that would significantly return investment to the state, but that is probably inconsistent with the mission of CPRIT. It's the unique role that we play. So that's a lot of the tension. I will say in the cases where we have taken equity, there have been places where we've been diluted to nothing. So equity is not the end all be all answer, particularly with CPRIT, but that's a topic for us to explore more.
And I guess my recommendation would be that before the retreat, maybe we have a meeting with the PDAC and say, okay, what are your ideas on how we could improve our standard terms?
Yes, and beyond even PDAC, others that are kind of in a similar space as CPRIT, if there's other creative options that we can think about. And Ken and I have talked about this a lot. I don't know if you have anything else to add.
No, not really. I mean, you may hit the major points. I mean, we have our statute, is such that, remuneration isn't necessarily at the top of the list. And there's a bunch of different things that we can talk about and we've thought about. So yeah, the retreat, probably a great place to do that.
Dr. Patel, did you have a question?
No, it's Ken answered that. And
Okay.
considering his age, he answered it rather well. But it's just sorry again. Happy birthday, Olga.
Yeah, rocking chair.
Were there any additional questions on the recommendations? Ken, you want to continue with your report?
That's it. That's
Yeah, thanks.
I mentioned it. Yeah. So
Okay.
we're going to do for 26-2, like I said, we're going to have between $7 and $8 million to do the supplemental awards like we did last time. And the RFA will be substantially the same as it was last time.
Any other questions for Dr. Smith? Okay, thank you. Mr. Burgess has certified compliance for the Product Development Research Award process. Dr. Rosenfeld has reported a conflict with DP 260231. Members, you have the list of applications and grant amounts recommended by the PIC for the Product Development Research Grant Awards. We will approve the PIC's recommendations if 2/3 of the Oversight Committee members present and voting agree. There are 9 product development research grant recommendations that we will consider in 2 motions. First, we will vote on the application that Dr. Rosenfeld has identified as a conflict of interest, and he will recuse himself. We will vote on the remaining 8 applications together in a second motion. If a member wants to consider one or more award recommendations separately from the vote on the slates, please make a motion to do so now. I will entertain a motion to approve DP 260231. All in favor vote aye.
Aye.
Any opposed? Hearing approval from at least 2/3 of the members present and able to vote, the motion carries. I note for the record that Dr. Rosenfeld recused himself and did not vote on DP 260231. I will entertain a motion to approve the PIC's remaining 8 grant recommendations for the following product development research grant mechanisms: seed awards for product development research, Texas Diagnostic and Devices Company Awards, and Texas Therapeutics Company Awards.
So moved.
Second.
All in favor vote aye.
Aye.
Any opposed? Hearing approval from at least 2/3 of the members present and voting, the motion carries. I will entertain a motion delegating contract negotiation authority to the CEO and CPRIT staff and to authorize the CEO to sign the contracts on behalf of CPRIT. All in favor vote aye. Any opposed? Members, Ms. Doyle notified the board on November 14th that she seeks authority to disperse grant funds in advance to the 9 companies we have just approved for awards. Are there any questions for Ms. Doyle regarding her request? Pursuant to the General Appropriations Act, Article 9, Section 4.02A, do I have a motion to authorize CPRIT to disperse grant funds via advance payments upon execution of any contract documents related to the supplemental grants and the successful completion of tranches to the 9 companies approved for awards today?
So moved.
Second.
All in favor vote aye.
Aye.
Any opposed? Motion carries. Members, closing out our action items for the Product Development Research Program, I will entertain a motion approving the fiscal year 2026 supplemental awards for product development requests for applications.
So moved.
All in favor vote aye.
Aye.
Any opposed? Motion carries. Thank you very much.
Thank you.
Okay, at this time, we are going to go back to item number 5, grantee presentation. The chair now recognizes Dr. Rekas to introduce Dr. Kiran Shokar, who will give a grantee presentation.
Thank you so much. Dr. Shokar, thank you so much for joining us. Behind tab 2, you have Dr. Shokar's bio as well as her presentation. So I will just very briefly introduce her. She is the chair of the Department of Population Health, a professor of population health, and the associate dean for community affairs at Dell Medical School at the University of Texas at Austin, as well as the chair of our Prevention Advisory Council Committee. So we're happy to have her here with us as well, but specifically today talking about Connect, which I know you all have heard about before. This was a very unique RFA for the prevention program, looking for a way to really deliver great, excellent information and programming across colorectal cancer screening for the state. So Dr. Shokar, thank you for being here and for your presentation.
Thanks, Ruth. Good morning, everyone. Thanks for inviting me to talk about this very exciting project that we are all very passionate about and committed to. So as Ruth mentioned, this was a special RFA of a different kind on the prevention program side. And it was really, it came into being because as we had experience over 10 years at that time with the colorectal cancer screening programs across the state, and we really, you'll be hearing a little bit more about them. We also realized that there's a lot more need across Texas that we're not being able to meet. So this mechanism came about to try and address that by optimizing, amplifying, and just being more strategic about how we really cover the state to really meet this excellent opportunity to make inroads into colorectal cancer, which is preventable and also detectable early. So it was there was a grant submission process, and we received the award, and we just completed 2 years of this work. So I'm going to present what we've done so far, how we kind of constructed the grant and this opportunity to really think of strategically across the state to meet gaps. So can I do this? Oh, thank you. So this is an overview of the grant. So essentially what we're doing is developing a comprehensive plan for a statewide colorectal cancer screening program, leveraging the work that's already happened, but ensuring that every eligible person that lives person eligible for colorectal cancer screening across the state, no matter what county they reside in, have a pathway to screening that's available to them and that they're knowledgeable about. So that's kind of the ultimate goal. And in order to get there, we just need to have a very specific understanding of what our assets are across the state in terms of the care pathway programs that are currently in place, but also identifying the gaps and challenges, and also what the infrastructure needs would be to really support that vision of every person that's eligible for screening having access to colorectal cancer screening. And our approach is very collaborative. This is very much a team sport. I'm just here as a spokesman and kind of grant holder, but this work is really very, very matrixed across the state, all kinds of sectors, all kinds of institutions and types of organizations. So that is really fundamental and key if we're going to do this. Can you go back? This is pragmatic approaches are very important, data-informed approaches, and also having embedded within what we come up with the ability to tailor what we do to specific geographies, populations, and needs and capacity in different parts of the state. And of course, we always have an eye on cost and cost effectiveness and how we can really leverage our funds to have maximum impact. So essentially, the first year or so was really about establishing this center and organizational structure and goals and specific metrics. A stakeholder network is extremely important for this kind of work because we need all different kinds of experts. We need representation from different areas of the state, representing different kinds of communities. And then we also need people outside of the care pathway that really understand the communities that they work in and what the needs, capacities, and resources are. And the idea really is to foster the adoption of best practices and evidence-based strategies into all areas of the state, not only the clinical delivery providers, but also in community settings across the state, and looking creatively at how we meet the gaps across the state. And then finally, the state is very large, as you know, and geographically and population-wise, we're going to have to prioritize areas according to need and other ways of delivering services in creative ways to overcome the substantial barriers that many people face for this. So that's kind of an overview. Next slide. So we came up with 4 goals. So first of all, really critical is a stakeholder network that's representing all regions and communities in Texas to inform the development, the implementation, and dissemination of a strategic plan for colorectal cancer screening across the state. So stakeholder engagement is really important. It's very challenging, but of course we're assisted these days with remote communication opportunities, so that really helps. We do have an annual meeting where we bring all stakeholders together here to Austin. We just had our second one. It was very successful in September. And that in-person interaction, exchange of ideas and sharing is really critical to keeping the energy alive and the passion alive and making sure everyone is aligned. So part of that stakeholder network is, the idea is that there's a bi-directional exchange of information. So we learn from people that are experts in their areas, whatever that might be, but also that we're able to share what we're doing and share best practices and provide opportunities for them to access education and training. So that bi-directional engagement is really important. The next piece is what we're thinking about is developing the infrastructure and resources to support expansion of evidence-based colorectal cancer screening. So as we think across the state, and you'll see in a couple of slides time where the programs are that are providing services, we do need infrastructure to thoughtfully to think about the infrastructure that's needed to meet the gaps across the state in terms of access and capacity. So there's a goal specifically devoted to that piece because it's essential for sustainability and also standardizing and thinking about things in an intentional way. Next slide. And then, of course, we are very mindful that everything we do is informed by data. So having robust evaluation methods and kind of really understanding what is going to give us the most impact for the least amount of resources, and also being sure that we channel those resources to areas of high need in a thoughtful way is really critical. So we have a lot of effort around modeling different approaches and understanding geospatially what the resources, challenges, and need is. And then cost considerations are also a big part of helping us to decide what we should be doing in a cost-efficient way and what are the implications of decisions of the components of the program in terms of impact you can have for a certain amount of dollars, et cetera. And then finally, you know, where overall the center's role is to really foster, disseminate, and amplify colorectal cancer screening best practices across the state. So there's a lot to unpack within that, but that's big picture. Okay, next slide. So this is the core team of the grant that's kind of overseeing the activities and providing the vision and also operational guidance. So it's a collection of individuals that are based here in Austin, some of them, especially the staff and a couple of the faculty, but also we have experts from Dallas, Houston, and other areas of the state as well. So this is what we consider the core team. Next slide. The core team is kind of covers the administrative core and the Connect leadership, but we also have a steering committee that's advisory to the work that we're doing, and that'll be on the next slide. I'll get to that in a moment. But we've organized our work around cores of expertise that are needed to really think through what is needed across the state. So we have people that are have expertise in clinical implementation. They're clinicians. They've worked in healthcare settings, and they are helping to figure out, you know, how we maximize delivery of colorectal cancer screening within healthcare settings. Then we have folks that have done a lot of work in community-based settings outside of academic health centers and also outside of clinics, and really being able to leverage community resources, community organizations to reach populations. And there's also expertise in engaging with communities and other kinds of stakeholders in an effective and inclusive way. and expertise in education and training, not only for healthcare providers and people that are providing services, but also for communities as well and individuals, and health communication between patients and providers. Then we have a whole set of individuals that are experts in quantitative data, modeling, simulation, and mapping, and able to incorporate cost into what is proposed. Then we have a very robust data and evaluation core, which is essential for not only developing the program in a data-informed way, but also being able to set systems in place that will allow us to evaluate our impact as we go forward, and also the impact of the current grantees. And then finally, we have a core which is devoted to policy development and policy recommendations, and how we attain and then sustain a statewide infrastructure and program. And then, of course, the foundational element to all of this is a stakeholder network, to ensure that we're really leveraging the expertise across the state of individuals with all kinds of backgrounds, and also that we're engaging with the people that are going to be providing these services across the state. Next slide. So this just shows you who's currently on the steering committee that's advisory and involved in providing input, guidance, and a way of disseminating the information that we have. So major academic medical centers are represented here, but also private organizations, nonprofit organizations, the American Cancer Society, Public Health Association, as well as the Community Health Center Association that oversees 72 different community health center systems across the state. So we've tried to keep this as broad as possible. We have an open mind and add people as we kind of come across them, and if there's an interest and a level of expertise or representation that we don't have. Next slide. So just to show you, that little red squiggle is Texas. And this shows on the graph, you can see the screening rates across all 50 states. And at the bottom is where you want to be, because those are the states with the highest colorectal cancer screening rates. So although we're at the top of this slide, we're actually in the bottom quintile of states in terms of colorectal cancer screening. So we have a lot of work to do still. And unfortunately, within each state, there's a distribution of screening that is really associated with whether you have access to healthcare coverage. And there's a big gradient for all SES measures, and also rural versus urban residence level, with rural populations having lower screening rates than urban populations overall. The UDS rate is the rate in the screening rate in community health centers, which are really tasked with taking care of people without access to healthcare coverage. And you can see the screening rate there is less than half the rate in the rest of the population. And then, of course, in Texas, we all know that about a fifth of the population right now between the ages of 19 to 64 does not have access to healthcare coverage. So we have a lot of barriers in terms of access as well as capacity to meet the need for screening. Next slide. So this shows the normal prevention program mechanism that provides grant funding for people to develop screening programs in their area. And you can see that right now there are about 12 grantees. Many of them have been in place for about over a decade, some of them. Some of them are a little bit newer, but they're very established in terms of their infrastructure, the communities they serve, and so on. And you can see that they're really centered around urban areas. But I have to say that when you look at their service coverage areas, they do cover every single county in Texas. And the way they do that is through creatively adapting their program so that it can be delivered remotely. Many times they're partnering with community health centers, and it's through them that they're reaching populations in distant counties. So That's infrastructure that through CPRIT funding we've been able to develop. And collectively, these program grantees can provide about 60 to 90,000 screenings a year across Texas. But unfortunately, that's only scratching the surface of what the need is. If you look at the insurance rates, healthcare coverage rates, and the eligible population for screening, what you realize is there's a 1 to 10 difference in what we're being able to provide versus what the eligible population might be. So we have a great place to start to look at infrastructure and how we connect and collaborate and network to provide more robust support and expanded reach in the counties across Texas to meet that need. So that's kind of our goal. Next slide. So this shows that if we were going to think statewide and what an organized screening program might look like, leveraging what's already happening and maybe adding in areas where there is need, this is what it would really take to have a robust, high quality program across the state. So this is kind of components, the leadership, obviously leadership, financing, governance, training of the health workforce that would deliver the services, having a care pathway in every single county, town, city, area that includes all the components, which is the screening, the colonoscopy for your diagnosis, and then access to treatment, which is oncology, colorectal surgery, radiotherapy, and so on. And then, of course, the information system, so you can track patients through the system to make sure that if they get screened, they're getting their diagnostic test, and then they're getting access to treatment and are actually being able to get that treatment. So these are kind of big picture of what you really need as part of an organized screening program. So next slide. So we have a lot of activity, which is targeted towards understanding the gaps, understanding the needs, and how we might leverage what we already have and how we would expand it into areas, and where are the areas that we would expand it. So these work streams are just working on different components to inform that plan. So the stakeholder network development, the clinical network development, this is the most challenging when you look at capacity across the state. And there's some maps you'll see a little bit later on, which really maps colonoscopy and also some other aspects of the care pathway. And you'll see a very similar pattern in its distribution to what you just saw with the program grantees, i.e. it's very concentrated in the urban areas. So that's good for the urban areas, but a fifth of our population lives in the rural counties. So we need to be really thinking about how we reach those, and this is part of what we're going to be doing. So other work streams are pilot programs so that new entities and organizations can develop their own screening programs, begin to 3 of those this cycle. There's a communication and online repository where we're compiling and creating resources for organizations that want to be part of the care pathway, so that they're not having to come up from scratch with processes, policies, communication, information. So that website is about to go live here pretty soon. And then we have the policy and attainability work group. We have a work group focused on making sure that we're collecting data similarly across the current programs, but also for the future, so that we can really show the impact that something like this would have going forwards, and we can measure it and demonstrate it. Navigation is very important to make sure people move through the cycle. So you can imagine the complexity of that if you're trying to create a program that serves every county in the state. So thinking through, we're in the process right now of compiling a document of best practices, and so that people will be able to access it. And if they want to create a program, they would be able to have that piece already done. And of course, the cost evaluation, and then the modeling and mapping. So I have a bunch of slides on some of these. I don't know if we have time to go through them, but maybe we could just quickly flick through them. So stakeholder engagement, we have regular meetings, we have work stream meetings, we have quarterly meetings, we're having a newsletter. So there's then we have the annual meeting. So we're really engaging in lots of different ways, and we're developing this repository. Next slide. The standardized data reporting measures. So as you know, CPRIT grantees, there are 12 of them across the state that are currently actively providing services. They have reporting requirements to CPRIT, but they also have their own tracking systems where they're tracking patients through the process. So they've all independently come up with these metrics and measures. So one of the things that we think is really important to do is to standardize the measures that everybody is collecting so that we can share and we can assimilate them together and really show the impact collectively. So there's a group that's working on that. We've got the data. We're working with each grantee to see what it would take, how they measure the data, so that we can have this, we can create a standardized table every year of the services that have been provided, the cancers that have been prevented, and the stages of the cancer, so we can kind of share all that data. So there's a group that's working on that. And then the other thing that we think is really important to do is to create a summary of our experiences in Texas across these grantees to explain how their programs were put together, what the outcomes were, and kind of best practices, and also learnings and how we problem solve, because I think that's a great resource of information for people elsewhere in other states to really learn from this kind of rich collective experience that we have in a state that's as large, broad, and as diverse as we are. So that's a work stream. Next slide. So one of the things that you have to do if you're really going to screen people across the state is have a network that they're going to be able to get referred to have their, if they get diagnosed with cancer, to have that taken care of. So it's the clinical network development is really key. And so we're working on that in a systematic way, working with colorectal cancer surgeons, working with, beginning to work with oncologists, and also the GI providers that provide the colonoscopies, to map where the services are, to understand what their challenges would be, and also what their interest level would be if we were to create a kind of hub and spoke model for colorectal cancer screening. And so we're in the process of doing that, and I'll share some of that data with you for a minute, in a minute or so. So we're doing that with all the key care providers so that we can kind of understand where we need to intervene, where we need help in terms of access and capacity. So next slide. So I mentioned the community health worker and navigator work group and the pilot programs. This is just a little bit more information about that. We're working on that standardized protocol, and those organizations are putting together new programs or improving programs that already exist for colorectal cancer screening. Next slide. This is the mapping. So if you look at the colonoscopy access slide, this is a map of all the ambulatory surgery centers and endoscopic services in Texas. And you can see, again, there are many, more than half the counties do not have an ASC endoscopy provider. So this is the challenge in trying to do screening. And, this pattern will be the same for oncology providers. It will, I imagine, we're collecting that information as well, and for colorectal surgeons as well. So what we're doing right now is we're mapping all the rural hospitals as well, because they could be leverage points or a critical part of the solution for access for people in the different counties. The map on the left is the health centers that I mentioned that are really taking care of a lot of patients that don't otherwise have access to care. And you can't see very well on this slide, but you can see that what we've done is we've mapped how many, from the data that they provide to HRSA, we've been able to calculate how many eligible patients they have that are not screened. And that could help us to prioritize areas where there are a large number of people that are seeking services in those health centers that we could have a very significant impact with, and it may help to prioritize where we start. And again, you see gaps in counties that don't have community health centers. Those are up. I think it's based on absolute numbers, but they might be as percentages. Next slide. This is a modeling and cost. So in devising a program that's statewide, even though it's leveraging these like hubs that exist around the state, there are lots of different ways that you can organize it in terms of a hub and spoke model, regional models, and if you have a fixed number of funds. What we're doing right now is creating a dashboard where you can play around with some of the ways you might compose a screening program and what that means in terms of cost and numbers of people that you're able to impact. So this would be really helpful for program planners and also payers to see what they, what kind of program kind of fits with their what their considerations are. And then so that's being developed. And then we're also developing kind of what the cost implications would be if we were able to screen a greater number of people and shift the stage to an earlier stage. What would be the cost savings? What would be the impact on, work days, et cetera? So that's something that we're working on right now. Next slide. Okay, yeah, so we're also not forgetting the patients and the community members that reside in the state. We do want to hear and understand currently what their barriers are, what their preferences are for how they would access a program like this. And specifically, we're doing a lot of work in the younger age group, younger than 50, who are new to the recommendation for screening because we know less about them. A lot of this work about patient knowledge, beliefs, barriers, etc., was done, like 20 years ago in the older population. So it's been a whole generation. We need to repeat this work in the community, but we specifically also need to learn more about the 45 to 49-year-old age group, the early onset colorectal cancers, population that's recommended for screening. So these are ongoing as well. And this will really help us to provide input into the plan in a way that the community is also going to be able to access it in a way that they want. Next slide. Okay, this was our second annual symposium where we brought together people from across the state, experts, etc. And then we also had them iterate on some of these questions that we're kind of working with. And it was a chance for people to meet people in person that they've been working remotely with for a while. So that was all I had. Thank you. I really appreciate the opportunity and hope that we're able to move the needle in the way that we need to for colorectal cancer screening.
Any questions for Dr. Shokar? Oh, yes, Dr. Rosenfeld.
Just a couple really quick questions. As part of this comprehensive system you're putting together, is there any biobank linked to this so you can go back in time and look at potential biomarkers or cell characteristics? That's the first question.
Okay.
And the second question is, with this huge database you're creating, is there any potential to develop a commercializable predictive test for colon cancer?
Okay, so both of those questions are more related to research. So I think that creating this system and especially the data infrastructure will really lend itself to being able to do that. It's not baked in right now into what we're thinking about because we're thinking about impact in terms of clinical services. But I think that with research support and, I think we will create an infrastructure that could support this kind of work for sure. There's a lot of potential beyond the clinical service delivery.
Thank you.
Any other questions? Thank you very much, Dr.
Thank
Shokar.
you.
Okay, now we're going to item 11. Ms. Doyle, please present agenda item 11, the staff recommendations for CPRIT's program priorities for the fiscal year 2027.
Oversight Committee members, you have behind tab 8 my memo regarding program priorities for fiscal year 2027. Hopefully, also you've all been able to talk in the subcommittee meetings with the various programs about the program priorities. We are not making any changes to fiscal year 2027 program priorities from what you have approved for the fiscal year 2026 program priorities. Mainly that was because we have 2 new chiefs. So this gives them an opportunity to, evaluate the programs and thoughtfully consider, with your input, if there are any changes that are going to be made. I will note also, we started doing this last year, and so we've done it again this year, where we've given you a dashboard of all of the program priorities, how they've been implemented since we started tracking them. We started tracking them in fiscal year 2016. And I guess just to back up, the program priority process was established in our 2013 legislative changes. So those were put in place in late 2013, started tracking them at the former chair, Pete Guerin's recommendation. And so we have many years of the implementation of the program priorities. And you've seen it just now with all of the programs reporting in terms of the awards, breaking down what priorities those fulfill. So we have a good source of information, and we really see how the priorities that you are establishing are changing the portfolio that we make. I always say when I talk about this externally to people, we don't put thumb on the scale for anything. We don't give, more points, or I guess in this case, since the smallest amount of points is the best, we don't give any advantage to somebody that has a project that is within the program priorities. We focus more on putting out specific requests for applications. You had this conversation on the early onset cancer earlier today. We established that as a program priority, I believe, last year or the year before that. And so, we're learning how do we need to get different reviewers? Do we need to talk about this differently in our RFAs? Do we need to be reaching out to specific groups to make sure that they are aware of the applications? That's how the program priorities are really shaping what ends up in our portfolio.
Any questions for Ms. Doyle? If there are no questions, I will entertain a motion to approve the fiscal year 2027 program priorities.
Second.
All in favor, vote aye. Any opposed? Motion carries. Thank you. Item number 12. Dr. Hebert, will you introduce Dr. Sarah Williams Blangero to present the Geographic Diversity Advisory Committee report?
I would just take a moment to thank Dr. Williams Blangero for making the trip up to Austin to make this presentation. You have her biography in the presentation in your packet. I just want to emphasize that she is the founding director of the South Texas Diabetes and Obesity Institute. So it's fantastic. And she's also the chair of the Department of Human Genetics at the University of Texas, Rio Grande Valley. So it's really a pleasure to have such an esteemed person lead our Geographic Diversity Advisory Committee. So Sarah, thank you for coming.
Thank you. Good morning. Thank you so much for the opportunity today to speak about the activities of the Geographic Diversity Committee over the past year. I am the chair of the committee. The Geographic Diversity Committee was formed because historically CPRIT support had been awarded primarily to cancer research and prevention projects based at institutions with or near an NCI designated cancer center. As CPRIT recognized, this pattern has implications for rural and medically underserved populations across Texas and for scientific workforce development. Next slide, please. Of course, the situation is not unique to Texas. If you look at the distribution of NCI designated cancer centers across the U.S., you see that gaps are present for rural and minority populations across the country. Next slide, please. In the state of Texas, we have 4 NCI designated cancer centers. 2 are located in Houston at the MD Anderson Cancer Center and the Baylor School of Medicine. 1 is in Dallas at UT Southwestern, and 1 is in San Antonio at the new University of Texas San Antonio, which merged UTSA and the University of Texas Health Science Center at San Antonio into one institution. Next slide. Yeah. To foster the growth of cancer research in areas distant from an NCI designated cancer center, CPRIT developed the Texas Regional Excellence in Cancer Awards, the TREC Awards. And the first TREC Awards were made in 2021, and the advisory committee was also formed that year. Next slide. The TREC Awards were designed to catalyze cancer research, recruitment, projects, and infrastructure at institutions located 100 miles or more away from the traditional cancer research institutions located in San Antonio, Houston, and Dallas. The first 2 institutions to receive TREC Awards were the University of Texas at El Paso and the Texas Tech University Health Science Center. Next. The TREC program was expanded in 2023 with the addition of 3 new centers. These were based at Texas Tech Health Sciences Center at El Paso, the University of Texas Rio Grande Valley, and Texas A&M University, bringing the number of institutions with TREC centers to 5. Next. While there are 5 TRECs, there are 8 institutions that are considered TREC eligible institutions, meaning that they can compete for TREC awards or associated funding mechanisms. These institutions tend to serve rural and medically underserved populations that lack easy access to the NCI designated cancer centers. So in addition to the funded centers, Texas Tech in Lubbock, Baylor University in Waco, and the University of Texas at Tyler also are TREC eligible institutions. Next. The Geographic Diversity Advisory Committee was charged with advising on how to grow capacity for cancer research at these institutions located 100 miles or more distant from an NCI designated cancer center. Next. Just to remind you of our membership, we have representatives from 7 of the 8 TREC eligible institutions on the committee, and we're hoping to add a representative from UT Tyler soon. Our members include Joseph Heppert from Texas Tech, Min Kong from Texas Tech Health Sciences Center, Mark Cox from UTEP, Raj Lakshmanaswamy from Texas Tech University Health Science Center at El Paso, Ken Ramos from Texas A&M, Kevin Penny from Baylor, and myself from the University of Texas Rio Grande Valley. Dr. Cox and Dr. Penny recently joined the committee following Rob Kirkin's retirement from UTEP and Dan Roma's rotating off the committee. And you might remember a couple of years ago, Dr. Kirkin gave this committee a wonderful summary of what has been accomplished with the TREC Award at UTEP. Next. I say this every time I give a presentation here, but I want to emphasize it again. The TREC Awards have a transformational impact on cancer research at resource-limited institutions. They don't just improve opportunities to conduct research on cancer, they make those opportunities for faculty at TREC-eligible institutions to conduct cancer research and to make advancements that benefit the populations that TREC-eligible institutions serve. To date, CPRIT has invested approximately $30 million to establish those 5 existing Texas Regional Excellence in Cancer Centers. Next. The committee recommended to CPRIT several new funding mechanisms that would be targeted to TREC-eligible institutions to support the expansion of research and training at those institutions. In total, 5 of the recommended funding mechanisms were implemented in fiscal years 23 and 25, resulting in an additional $8.6 million awarded to TREC-eligible institutions to support the acquisition of major instrumentation, pilot studies, postdoctoral training, core facilities, and targeted innovative individual research awards. Next slide, please. Thus, a total of $38.6 million in CPRIT funding has been awarded through programs that are specifically targeted to TREC-eligible institutions since 2021. On average, across the years, that works out to approximately 4.5% of the funding awarded through CPRIT's academic research program. Next. Now, of course, TREC-eligible institutions can apply for non-TREC mechanisms. So if you look at all the funding that was received by TREC-eligible institutions, they received approximately $39 million from TREC-related programs, $43 million from non-TREC related mechanisms, and about $26 million from the Prevention Program Awards, for a total of about $108 million. Next slide, please. The previous slide showed that on average, about 10% of CPRIT funding awarded between 2021 and 2025 from both the academic research program and the prevention program went to TREC-eligible institutions. Next. At TREC-eligible institutions, where there's not necessarily a large cadre of researchers working in cancer and the availability of high-cost instrumentation may be limited, there's a need to balance the funding across research projects, supportive training programs so that the institution can grow their own future researchers, instrumentation and core facility support that will provide the needed infrastructure for those scientists to succeed, and pilot study funding to allow investigators to generate the critical preliminary data they need in order to compete for NIH funding. All these elements are critical to growing research at TREC-eligible institutions where we want to increase the number of scientists engaged in research, develop a pipeline for future scientists who will focus their research on cancer in these geographic areas, foster new ideas in research, and provide the infrastructure necessary to conduct research. Next slide, please. Supporting research at TREC-eligible institutions has benefits that are due to the communities these institutions serve. Many are well-placed to study cancer health disparities and to conduct research with medically underserved populations that are also underrepresented in biomedical research. There's great potential to increase the scientific workforce that is devoted to cancer research, and by supporting TREC-eligible institutions, CPRIT is building capacity for cancer research across all of Texas. Next. One of the recommendations that GDAC made was to provide support for clinical trials infrastructure development at TREC-eligible institutions, and we were very pleased to see the announcement of the Rural Oncology Trials Accelerator Award earlier this year. This mechanism is targeted to organizations in rural areas to help establish or enhance clinical trial capacity in rural and underserved communities by supporting infrastructure, staffing, and operational costs. The applications for this award are due on December 2nd, and the first awards will be made in May. So we're looking forward to seeing those awards and improving opportunities across Texas to participate in clinical trials. Next. The GDAC discussed another potential mechanism that leverages the strengths of TREC-eligible institutions at its most recent meeting, and we hope to develop a formal recommendation at our next meeting. This new mechanism would support collaborations between TREC-eligible institutions and those institutions that have or are near an NCI-designated center for research that is focused on medically underserved populations. By leveraging the strengths of both types of institutions, we hope that the impact of cancer research can be broadened to more Texan communities. Next. We have also discussed some ways in which a rapid expansion of cancer research at TREC-eligible institutions may occur. One change that could be implemented relatively easily is to allow for more than one application per institution for the funding opportunities that have limited submissions. TREC-directed grant mechanisms sometimes only allow for one application per institutions when there may be multiple meritorious applications that could be considered for funding. Another way in which growth of cancer research can be fostered quickly is by attracting investigators who are already at these institutions in different areas of research and encouraging them to focus on cancer. This could have the additional benefit of bringing innovative new ideas and approaches to cancer research. Next. If we look at the national picture, we see again how critical CPRIT funding is to TREC-eligible institutions. The National Cancer Institute has over 1,000 grant awards that are active in Texas, and about 850 of those are at one of the 4 institutions with the NCI-designated cancer center. There are 35 NCI grants that are active at one of the 8 TREC-eligible institutions. Next. And of course, this year we learned that CPRIT funding can be critical when the national funding environment changes. Changes in national funding priorities and the lapse in government funding both impacted NIH-funded projects. And NCI back in May was among the top 5 NIH institutes that had grants terminated on a temporary or permanent basis. Next. So to sum up, CPRIT now has 6 grant mechanisms that are specifically designed to support the transformation of cancer research at TREC-eligible institutions. To make TREC-eligible institutions more competitive for both CPRIT and NIH funding, investment in research, infrastructure, and training is required. Next. To get back to the point I made earlier, CPRIT funding to these TREC-eligible institutions is transformational for expanding research on cancer, growing the Texas workforce focused on cancer research, including underserved populations in basic and clinical research, and positively impacting the health of communities throughout Texas. Next. The Geographic Diversity Committee meets quarterly, usually by Zoom. We're excited this year that we will be having an in-person meeting in association with CPRIT's Innovations Conference to be held in October. On behalf of the committee, I thank you again for the opportunity to give you an update on our work, and I'd be happy to answer any questions. Thank you.
Are there any questions for Dr. Williams-Langero? Dr. Rosenfeld?
Very nice presentation. Thank you. Just had one question, looking at the TREC map. I noticed that there's no star near Amarillo, and I was just wondering, are there any plans or applications for our citizens in far North Texas?
Right. So I think that's a CPRIT decision on who is considered a TREC-eligible institution. We started with 7. We've added Tyler now, and yes. So they're exploring it.
Thank you.
Dr. Patel?
Thank you very much for that presentation. I appreciate that. Does the committee have data as regards the number of private practices serving rural areas in Texas, and are we collaborating with them? I'm just curious about that.
No, they don't. We've talked a lot about having the Geographic Diversity Committee meet in conjunction with the Clinical Trials Committee to kind of work on that issue and figure out how we can leverage those resources across the different parts of Texas.
And because one of the, maybe I'm wrong, please correct me, is that the private practice oncologists in the state of Texas do take an extraordinary burden of treatment of patients, and accessibility for them to trials is rather difficult. It is difficult. I wonder if the Geographic Diversity Committee will strongly look into this and provide us data.
Yeah, we
lines.
will take that on as a task, yes.
Thank you very much.
Mr. Margot?
You know, my concern is the making sure that the TREC eligible institutions, and especially the 5 who've already received grants, are applying to these other opportunities. I just don't know if there's a way we can know in advance if they are putting in an application for, because they're only TREC eligible. They're designed only for those institutions that are TREC eligible. I just want to make sure they got their act together and they're applying appropriately.
Right, so for each time a TREC mechanism has been offered, there have been adequate applications for each competition, and something has been selected out of each competition. So that says that applications are coming in. For my own institution, I know that the TREC support has led to applications both to the different programs that are offered through CPRIT, but also to NIH as they seek to grow their funding.
Well, because, you know, with TREC, it's really not a competition because they're all eligible for the grants if they can qualify. And I'm just want to make sure that the institutions that, especially those that have already received funds, are applying to those add-on opportunities to expand what they have, which is absolutely critical as we go forward.
Right.
I don't know if there's a way we can, Kristen or whatever, or Scott, find out if are they doing it? Are they applying? And if they're not applying, then some of us in those areas need to say, why not?
Yeah, and building on this question, what do you guys, ladies and gentlemen, what do you see as barriers for these 7 organizations not applying or being repetitive in applying? And I don't even know if it's competitive or not, Kristen. Are they all 7 can apply and all 7 get awarded? Is it a limited bucket? Because I thought it was limited, is it not?
You have to go through the period process.
But I mean, the funding is limited.
No, the funding, my understanding is funding's available, period, for those institutions that TREC. It's not like they all compete. The 5 compete for the same dollars. They don't. It's separate.
Is that true?
Usually we have buckets set aside for TREC RFAs if we issue an RFA. So the money is there, but the applications have to go through the peer review process and they have to get a great score, right? So there is a level of excellence that's required. That being said, you know, as a state agency, we can't really go out and ask people to apply. We can issue the RFA, and then we can encourage,
we can find out,
communicate,
as the stated already.
Yeah,
why they're not.
You know where they're applying.
Right.
Yeah. So I can tell you that what we've seen in the portal already is a couple of these rural oncology applications coming in. They've been started. So that's all we can do. Can we go back and say how many of them are applying, or I think typically when we have an RFA, we do get applications. The part of this discussion that I want to make sure that we try and accomplish is that, at least for me as an investigator, the one thing that's always frustrating is if, you know, a government agency puts up an RFA 6 weeks before the due date, and I don't have time to apply because I've got other commitments, and
even if I had a great project. And that's why I want to do things in a more consistent basis. So because some of these center awards might take a year or two to develop. And so I want the Trek institutions to know that there will be an RFA there for them if they develop something that's truly special that will fund it. So that consistency, I think, is important for planning. Then they have no excuse. We should get applications. Absolutely.
And then another point is that, as said, about 43 million in non-track related mechanisms was awarded to track eligible institutions. So they're both applying for the mechanisms that are targeted to them and also for the general mechanisms. And I mean, we have some very excellent scientists at these institutions who are able to compete on both mechanisms.
And really a key metric long-term for us is how many of our Trek-funded investigators go on and graduate to NCI-funded investigators or other NIH institutes. We want to leverage the federal funding with the CPRIT funding. So it is very important for us. If we give pilot funds, we want to see those preliminary data then develop into either larger CPRIT awards or NIH awards. Or American Cancer Society awards, other sources so we can really expand those institutions and the impact that they have in those regions.
Right. Well, this is it's still amazing what the progress has been made. I'll just remind of Kristen and administration. Remember, we have a lot of funding that we do on things that may never come to pass. We have a lot of high risk, which we consider because of your staff. We're going to award those projects that may never have any return. It's super high risk, and we know it. Yeah, same measuring stick when it comes to these 7 institutions, and people tell me, well, it's just not high quality. Well, you're certainly willing to take a risk on a microscopic study that, quite frankly, if you look at our attrition rate or conversion rate, it's not very high, but as an administration, you're willing to take that risk. I would just ask the same measuring stick be used when you award these, whether it's El Paso or Amarillo, whoever it is, same measuring stick. You want to take risk on a mitochondrial study that probably will never turn into a drug for 20 years. This can be impactful and transformational in Amarillo or in Lubbock, whoever it is. So that's all. I just want to make sure that we're same measuring stick.
Absolutely.
Oh, yes, Dr. Cumming.
Just wanted to bring to your attention, Dr. Williams-Brangero, that Dr. Shokar's presentation just moments ago regarding the mapping of access to care, specifically in that situation was access to screening endoscopy centers in Texas, the map that she showed, but they also talked about what the next step would be if cancers were detected and access to treatment. And to Dr. Patel's question about what are we doing or how are we identifying or how are we connecting with rural oncology providers that are outside of an academic institution, there may be some synergy with what they are doing in finding the Rolodex of the map of those providers in the state and what Dr. Patel was asking. Just wanted to bring that to your attention.
Lots of potential for leveraging that has come up at this meeting for sure.
And certainly I would point out that our rural oncology award to build infrastructure is not limited to an NCI funded designated cancer center or even one of our academic centers. It can be a community-based practice that could apply. So that's wide open. And I really appreciate your comments because and the differentiation, if it's a service, it's prevention. If it's research, it's in academic research. And I'm super excited to have Ruth as a colleague in the offices, and we're going to be putting together plans for research that can really leverage both the services that are being done and the database that Dr. Shokar mentioned, and we can then collect the biosamples and really do some research. So really excited to have Ruth on board.
Any other questions? Excellent presentation. Thank you so much. We appreciate you coming. Okay, item 13.
The chair now recognizes Mr. Ellis to discuss the proposed administrative rule changes.
Thank you, Madam Chair, committee members. As is often the case in state government, I have bad news and good news. The bad news is you have to talk to your lawyer right now. The good news is because I'm on the dais with you, you don't have to look me in the face while I do it. But I'm talking today because we're seeking the Oversight Committee's approval to publish some proposed amendments to section 703.24 of CPRIT's TAC rules. You'll find the materials related to those proposed administrative rule changes behind tab 10 of your board book. I did want to note at the onset that we're just seeking permission today to publish those rules in the Texas Register. That's the first step in the process. If the committee grants its approval today, we'll get those over to our friends at the Secretary of State's office. They'll go in the Texas Register, and members of the public and stakeholders have the ability to give us some feedback on those rules. And, we may need to revise those rules as necessary based on that feedback. And we'll be back to the committee if we're ready to move to adopt that rule. So we're proposing an important but relatively straightforward change to the section, which essentially provides notice to grantees and to the public that CPRIT can't consistently meet the default rule that was established by the Texas Grant Management Standards, that financial status reports will be reviewed and any deficiencies noted to the grantees within 21 days. As all of you will be aware, the Texas Grant Management Standards is a statewide standard for every kind of grant program. And so it's sort of a default set of rules, but it makes allowance for individual agencies to vary from those rules by going through a rule-making process and stating a reason for that variance. So as you'll also know, our internal auditors took a look at post-award grant monitoring last year. They made some notes about the timelines for review and about whether or not we had established certain standards. They noticed that sometimes we're unable to meet the 21-day standard for review and notifying of deficiencies. And they noted we hadn't formally set a policy that we will review and make payment within 30 days of receiving a complete and correct FSR. So in response to that report, senior management sort of formed a team and has been looking at all of our policies and procedures related to FSR review. At the same time, most of the folks working on that have also been working on CPRIT's new grant management system that's been mentioned several times. Through the process of working through both of those, we've reached a conclusion that we can't fully complete that review at this time without going alongside that new grant management system. We were in a very early stage when we started this review, and we made a lot of great progress improving some of that documentation. But through the exploration of a new grant management system, we've discovered what some of the capabilities are in terms of data, in terms of process management of a modern system, and what some of the limitations are of our ability to actually get data outputs to help us make good decisions about what those deadlines and processes should be. We have the data, but we don't have the ability to extract it and analyze it the way we need right now. So that means that we need to review those things alongside one another. Looking at the status quo, our compliance team does a fantastic job training new grantees on what's expected of them and really helping them to understand coming alongside them. And our grant accountants do a very thorough job as is reflected by the low error rates that we get out of that. But it doesn't change the fact that what CPRIT does is very unique, that there's an incredible variety of highly specialized expenses. So both specialized knowledge and judgment calls go into every single FSR that a grant accountant is reviewing. And that means that it's not easy to apply a sort of across the board default rule to that circumstance because it's so very different than most of the grant programs that the state had in mind when the Texas GMS were developed. So, just the variety of expenses, the extreme rarity and complexity of, say, if you're analyzing personnel expenses, well, the extreme rarity and complexity of the skills and expertise that a researcher has, the unusual knowledge of specialized equipment and tools, all of those things add up to just a substantially different circumstance. You know, what we do with regard to what those timelines should be needs to be informed by data that's specific to CPRIT and takes all of those things into account. So, you know, we're working diligently to obtain that data, but again, we probably won't be able to obtain all of that data until we have the new system. So we're proposing for the time being to adopt this rule amendment as a temporary measure until we complete all of that review, completely revise those procedures and have the data points so that we can make firm commitments with what those review timelines should be based on actual data that takes into account all of our circumstances. So the proposed rule changes provide that we will always review and make payment within 30 days of receiving a complete and correct FSR, but does make it clear to the public that we are not able to commit that we can always make that first review and notify of deficiencies within the 21 days at this time. It also provides an additional measure of transparency by providing that if we're not going to meet the deadline that we have established, that can be waived, but only after the CEO provides a notice to the Oversight Committee, which is also published on our website and included in the relevant grant files, that we're not able to meet those for a specific amount of time up to 180 days. So again, we anticipate revising this rule again in the future once we have the data to really make those decisions, and we have a new system in place that will really allow us to know what our in-state of business processes are going to be. You know, it's possible, and I think likely, that 21 days might not be that number, but we think we can reach a firm number in the future even if a longer period is required. So that's basically the proposed rule. Thank you for your time. Happy to take any questions.
Are there any questions for Mr. Ellis?
Yes, one.
Dr. Hernandez?
Oh, sorry. Go ahead.
Resources? Do we need more resources? We certainly don't want to leave them out of work and we don't have tools now.
So it's difficult to say based on the data that we have right now, because I don't have the ability to generalize and say what's causing all of the delays. Our folks have a lot of work to do. They have a lot of work to do on a given schedule. That's one of the considerations, is the timing. I'm always saying it's the volume, timing, and complexity of these FSRs that come in. You know, they're submitted on a quarterly basis. People being what people are, they tend to submit them at the last minute. So they tend to come in a very high volume. Given the complexity of those submissions in many cases, and not all of the submissions are incredibly complex, but many of them are, you know, just the review timelines are something that probably needs to be looked at as we revise these business processes. But I don't feel that we have enough data points to know exactly what those resource needs are, whether it's just people in a seat or whether it's we need certain technology tools or certain business processes to streamline that at this time. So I hope that we'll be able to get those answers, but we don't really know.
Yeah. Mr. Montgomery?
I'll add very quickly to what Mr. Ellis said. This is, one of the main reasons we are moving to a grant management platform. We continue to be limited by some of the constrictions with our current grant management platform, and those limitations then ripple out. Having Mr. Weaver in place as our Chief Financial Officer, that was a new position that was created that has helped provide more guidance and structure for the grant accountants. We are seeing the backlog, has rapidly been reduced even over these past two times. And like Mr. Ellis is saying, we've got some good data points right now, but there are just a few data points now that we have that were, up to speed in terms of the number of grant accountants that we have, the guidance that's being established, these other issues. We want to play it out a little bit longer to make sure that whatever rule we do put in place, final rule, and like Mr. Ellis said, this is kind of a temporary issue right now as we're getting more of this data. But finally, what can we live up to, and what can our grantees expect? So. Mr. Montgomery?
Just wondering, in your, Mr. Ellis, in your analysis, you talk about the public benefit and you say these amendments will result in timelier payments to grant recipients. How does extending the deadline result in timelier payments to the grant recipients? I don't get that.
It allows us to focus on processing them in an order that makes the most logical sense and not redirect resources to trying to focus on the deficient ones. For instance, focusing on the 21-day deadline allows us to shift, or causes us to shift resources to ones that are going to take longer to pay over ones that we can pay now.
Dr. Patel?
Ms. Ellis, the question is what's the timeline that you're looking at to gather the appropriate data and then make an informed decision regarding policy changes? How long will it take? A year, 2 years?
So some of it is key to having the new grant management system in place, which I would have to double check because I should know that, but it's been a long morning already. At the end of 2027, we'll have that. But I don't think it's quite as simple as that because we're working right now. We continue to work on improving the business processes as we identify the problems. I work with both our chief financial officer and our chief compliance officer regularly, talking with them about how do we identify areas where we can clarify or streamline the review system. So improvements are being made now, but we may not have all of the data points until the system's in place in 2027.
In 27?
I believe that's correct.
Any other questions for Mr. Ellis? Okay. Members, is there a motion to publish the proposed changes to Texas Administrative Code, Chapter 703 in the Texas Register?
So moved.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Members, we will take up agenda item 14 later in the meeting. Turning to agenda item 15, the chair recognizes Mr. Weaver to present the Chief Financial Officer's report.
Good morning, members. Glad to be with you here to present an overview of our FY 2025 financials. Just a reminder, as we're heading into Thanksgiving here, we're actually in fiscal year 2026, about to close the first quarter, but this is a retrospective look back at the year that was and the fourth quarter that was in 2025. So as you see from your presentation materials regarding the budget, we finished the year in FY 2025 with total expenditures and encumbrances of our initial $297 million operating budget at 95% expended or encumbered. That includes the $256 million of grant awards that y'all authorized last year, comprising about $26.4 million in prevention awards, $156 million in academic research, and $74 million for the companies. In a normal year, that expended encumbered amount percentage would probably be closer to 98, 99%. But as we've talked about quite a bit this morning, most of that fallout is the $11 million that was appropriated for the grant management system replacement that will be carrying forward to 2026, maybe even to 2027 as we close out that project. Moving on to revenue sharing, we received about $315,000 in the fourth quarter of FY 2025 to bring us to a little over $1 million on the year and about $11.5 million from CPRIT's inception. As I've kind of mentioned before, over that, or I should say, just in the last 4 years, we've taken in about 57% of the total revenue generated since the agency's inception 18 years ago. So positive trend that we hope will continue, and we'll be monitoring and updating you on that. Specifically on our our favorite royalty item, the Wellereg royalties that the agency is receiving. We received the second quarter 2025 royalty payment in the fourth quarter of fiscal year 2025. It was about $240,000 or a year-over-year increase of 29% from that period in 2024. One particularly interesting note, I found it interesting, hopefully you'll agree, is that you may recall from prior updates, we've discussed that Merck is studying the drug for new indications in its existing markets, but also establishing regulatory approval to sell the drug in several new markets. And that's kind of a leading indicator for what we're seeing on our revenue payments, royalty payments. And so for that second quarter 2025 payment that we receive, compared again to a year prior, we're seeing sales for the first time generated from several new markets, including big ones like China, France, and Germany. Those are very nascent markets, but again, we're just finally seeing some revenues trickle in for the first time. So that's something we'll continue to monitor. And again, hopefully that's a harbinger of good things to come. We'll keep you apprised as that develops.
The Wellereg royalties that we receive, that was not under our standard revenue sharing that we adopted. That was one of our first awards that we made. So those were individually negotiated. So the royalty amount that we receive is actually 0.125%. Versus you've heard us talk about the royalties that we look at are 3%, 4%, 5%, based on sales with a 0.5% royalty tail. So the amounts would be much greater that we would be receiving if we were under the standard revenue sharing that we have now. The other issue with Wellereg that's different is that we did receive milestone payments. We did away with milestone payments when we adopted the standard revenue sharing. Those milestone payments, were significant when we received them. It was our first $1 million check, but the royalty that we receive would actually be much greater, if you kind of play with all of those levers.
Moving on to the performance measures, as y'all are aware, the agency has established and agreed with state leadership on 5 key performance measures. We report 2 on a quarterly basis and 3 just annually. So I'm glad to report that the agency has achieved or exceeded the performance targets of 4 out of those 5 measures. Last time we all met, there was some discussion of how our prevention services stack up to the sort of high water mark that we had seen in the pre-COVID era, and obviously it dropped off a little bit. And as we've been coming out of COVID, we've seen those measures rebound. And we were projecting, again, 3 months ago, as we had closed out the third quarter, that we would set a new high water mark. And I'm happy to report that we served just over 1.1 million people with those prevention services in FY 2025, which is far exceeding the 950,000 or so that was the benchmark from back in 2019. So again, positive trajectory there. Regarding the company relocations, as we heard a little bit earlier in the product development update, that's an area we continue to look at. Unfortunately, in 2025, we didn't have any of those, but we may see those resume next year. And I would remind you all as well, during the strategic planning process, the agency collaborated with state leadership and agreed with the governor and the LBB to reduce that target on the company relocations from 3 down to 2. And so hopefully that's maybe a little more right size for what we can see as we head into 2026, 27. In addition to those 3, the annual measures, the age-adjusted cancer mortality rate performed about on target. The number of articles published from CPRIT funded research projects exceeded the target of 1,000 with 1,132 for the fiscal year. And finally, the number of jobs created and maintained was well over the 3,000 target at about 3,800. So again, 4 out of 5 ain't bad. Moving on to our debt issuance. In the fourth quarter, we issued the final tranche of our FY 2025 funding of about $64.6 million in June. Because we met in August, I think I mentioned last time we spoke that we then worked with TPFA to refund those short-term commercial paper notes out into long-term bonds, which will be general obligations of the state, but because it's a point of interest for some of you all, those were sold at an all-in rate of about 5%, and again, a taxable rate. So pretty good. And again, evidencing the state's credit and the very efficient cost of capital that we're able to tap into as an agency. And finally, just as a data point, that brings the inception to date issuance for CPRIT of just over $3.4 billion. Those are the high points of my financial report, and I think contracts are net. So I'll stop there, but happy to field any questions or elaborate on anything we discussed.
Any questions for Mr. Weaver? Dr. Hernandez?
It goes to a special interest in sinking fund that the state controls and is applied to repay the debt. To service the debt. You are, and this helps defray what you as taxpayer, we all as taxpayers are paying to service the debt. Oh, it's pretty transparent, but yeah.
Any other questions for Mr. Weaver? Okay, thank you very much for your presentation. Okay, item 16. Mr. Weaver, please continue with the proposed contract recommendation.
Sure. Again, as y'all heard a little bit earlier during the product development overview that Dr. Smith presented to you, we have good news and bad news, as our current phrase or borrow phrase from our general counsel. When we originally scoped our contracts for the fiscal year and brought them to you during the August meeting for those contracts that we anticipated to be over $100,000, which by our policy requires your approval. We thought we would have a little bit lighter slate based on historical trends for our product development awards. Turns out, given the current funding environment and other, we had a very healthy number of applications, both in terms of quantity and quality. And because of that, instead of the 8 or so that we had anticipated progressing to the due diligence review stage, we had 14. And so with that, it's likely that these 3 contracts, contract with Allen Boyd's for due diligence services and the 2 outside counsel contracts with Norton Rose Fulbright and McDermott, Will, and Schulte, formerly McDermott, Will, and Emery, will exceed the $100,000 that, again, requires your approval. And so those are the 3 contracts we're bringing to you at this time. We have a current not to exceed on all 3 contracts at just under $100,000. And we'd like to bring the 2 outside counsel contracts up to $149,000 each and restore the Allen Boyd's contract to its historical level of $330,000. But I would just remind you all that those are not to exceed amounts, and it's very unlikely that we would approach those caps.
Any questions for Mr. Weaver? Dr. Hernandez?
They are.
We can bring up Dr. Smith for the question on Boyd's, but I know for outside counsel, that's billable hour. I don't know if it's hourly for Boyd's.
Mr. Weaver, Mr. Montgomery wants to know why his boarding pass is such a high number.
Is there someone who can speak to the intricacies? No, it's because we share the Oversight Committee's commitment to efficiency and providing the bang for the buck to the taxpayers of the state of Texas. And so I appreciate y'all finding those efficiencies with us as we right-size our travel program.
Peter Martyr.
I just wanted the minutes to reflect, I did not ask that question.
Let the record show it was Mr. Margot. Okay. Any other questions from Mr. Weaver? Okay, is there a motion to approve the fiscal year 2026 contract not to exceed amounts with Allen Boyd's Consultants, Norton Rose Fulbright, and McDermott, Will, and Schulte? All in favor, vote aye.
Aye.
Any opposed? Motion carries. Thank you.
Thank you all.
Moving on to agenda item 17, the chair recognizes Ms. McConnell to give an update on the 2026 CPRIT conference.
Good afternoon. I don't have a written memo because there isn't like concrete information to report, but we have been working with IEM, our event manager, on the CVent website for the conference. So working on the sponsor registration, which will all be online, which will be great, as well as the just general registration for attendees. We will be opening the conference registration. I anticipate opening that in December as we reach out to potential sponsors for the conference. And then in late January is when we plan to release the registration for just general attendance. We will have a 3-tiered attendee, so trying to drive early registration. So, the price will go up gradually as we approach the conference. But we, kind of historically, we have had about 700 to 750 attendees. So we anticipate that same attendance. I think, we've heard from some grantees. They're very excited that we're having a conference again. At this time and the programs have been working on the agenda. They've been brainstorming about things to bring forward for our plenaries and breakout sessions. And they're actually looking at potentially having more kind of interconnected sessions. So we'll have larger plenaries versus some of the breakout sessions that we've had in the past. Are there any questions?
Would you repeat the date of the conference for us?
It is October 5th through 7th, 2026.
Thank you. Dr. Roosevelt?
I can't wait for the conference. Just a few questions. For this year's conference, will there be CMEs available? First question. The second question is, are there any ideas, a couple of things that will be new at this meeting as opposed to the previous meetings? And the third is, how are you going to identify more sponsors? Because I think there should be a lot of sponsors who would be interested. And I was just wondering how you're going to inform all the various parties that the sponsorships are available.
Okay, so the first question on CMEs, we don't plan to have CMEs. We haven't had in the past. There's a process you have to follow, and I think the program also has to reflect whatever level of CMEs you have. So we haven't actually pursued that. And I don't know that at this point we have the capacity to pursue that. I can look into it a little bit more. Your second question was on
new things that are new or different.
Until we have the program, I don't have an answer for that. I think, yeah, I don't really know that what will be new and different from what we've had in the past, but I think there are things that have come up, like topics that might be different from what we've discussed before at the conferences.
And just speaking for us, like practicing doctors, it'd be really good if you would, if there'd be a path towards CMEs.
But it's something we can do. Right? We haven't done it. I understand that, but it's something we can do if we decide to do.
I think so, but then we'd have to design the program kind of more specifically for that. But I don't know what some of the requirements are to have any of the CMEs.
Definitely get 12 months to figure it out. If we want to see it means, I don't know what to do. It does make a big difference. Definitely,
Okay.
be great.
Uh-huh. Yeah, no, we'll look into it and see what we can do. I'm sorry, you had another question? Our actually IEM, obviously they'll reach out to our prior sponsors, and then they've come up with a list of some additional sponsors. We'll also be, sending out notices through our listserv, and then just trying to get the word out at various events that we attend about the potential for sponsorships.
Just kind of looking at sponsors that, companies that have sponsored events in Texas, like IC3 and TMC events. So I think there's a rich pool of potential sponsors.
Mm-hmm. Yes.
What percentage of people who receive money from us, whether it be name something Baylor or some private company, what percent of all the people that receive funds from CPRIT and are asked to participate, because we want to see what they're doing and present their data? If you had a guess, what percentage of them actually participate in our conference? Who's sponsoring?
Sponsor? They can't sponsor. They can't sponsor. If they sponsor a conference, then they lose their grants. We can't make grant awards to them. Yes. So. No, nope. That's actually prohibited under the law.
We are different than many state agencies. We have a death penalty provision in our statute that says if any grant applicant or grant recipient makes a gift to CPRIT or a related institution, a related foundation makes a gift to CPRIT, then that entity is ineligible to receive awards from CPRIT. It doesn't come with a lot of guidance. It's different than the penal code. So the penal code also has, a lot of guidance on gifts, and it provides a lot of exceptions, but those are exceptions to prosecutions, not calling them gifts. So we do not want to do anything that would potentially jeopardize having an institution become ineligible. I think to Dr. Rosenfeld's point, though, there are many kind of support entities around, manufacturers, a lot of people that want to get in front of our grantees, and that's something that we can certainly look at.
Oh, yes, Dr. Patel.
The mere fact that you mentioned the penal code science. But my question is, will there be an open session with the three heads that we have? We'll sit down together and talk about their thoughts and ideas, and especially in terms of not forming silos and cross-pollination. It'll be a wonderful open discussion to have when you bring this in, that people can ask relevant questions.
I think since you mentioned it, they'll consider it. So.
The three won't like me.
Any other question? Thank you. Thank you. Okay, item 18. The chair recognizes Mr. Leffler to update us on CPRIT's communications activities.
Good morning, members. It's still morning, and Madam Chair. Good to see you. I've got my memo in book, and I don't have a whole lot to add to that, other than just two things. We are still continuing to try to improve our news clips that we send out. Justin does a fantastic job compiling all that, so a lot of that credit goes to him. We're looking to improve it. We may get another service. So if you're receiving those and if you enjoy those or you think that can be improved, please let us know. Just reply to that email and we'd love to get the input because as I said, we may get another service to try to improve that. And then also if you happen to be around the TV around 4 o'clock, 4:15, Kristen's going to do an interview with KXAN local TV here. So either TV or online, try to tune in and check that out because she always does a fantastic job. So
You and my parents can watch.
other than that, I'm happy to answer any questions. Really, our focus is annual report and conference right now.
Any questions for Mr. Leffler? Yes, Dr. Roosevelt.
Just a quick comment. I really appreciated your coverage of CPRIT, so thank you for that.
Thank you.
Any other questions? Thank you very much. Item 19. We've all been awaiting this report. The chair recognizes Mr. Graves from Weaver and Tidwell to present the internal audit report.
Thank you. Get excited. Internal audit's always exciting. Depends on who you talk to, I guess. For today is just an informational report. We are underway in our internal audit plan. In your packet on page 15-1, you'll see our summary. We have 3 audits this year: information security, intellectual property compliance in the post-award grant monitoring space, and then an advisory engagement over the SAO efficiency audit readiness. We have started on that. We've held several meetings with management. It's a little bit of uncharted waters as far as the state goes because it's brand new, but we are working our way through that. And the CPRIT management team has been helpful in getting us information. So we are underway there. We have also started planning for information security. So we held an early planning meeting. The real work won't start on that until the new calendar year. But we are underway, starting our planning there, really narrowing in. And our focus this year in internal audit is we've had broad audits in the past over large topics. We're really trying to focus in on the areas within those subject matters that make the most difference for CPRIT. And so we're working with Soma and Shannon to define those specific areas in information security that we're going to work on and dive into the scope in a deep manner. So we're working with them on that. So those are the current activities under this quarter. We also have plans in the spring for our follow-ups on post-award grant monitoring, our non-grant expenditures, and the recommendations we made for the P-card advisory audit from last year. Just one other item of note on page 15.3 in your packet. We normally have a multiple table of all the open internal audit findings, but happy to report and show you that the agency has really made a lot of progress. We only have findings open from the last year's audits. And so the 9 that are open are the only ones that are on that table. So there's no need to present prior years for that they've all been closed. So that is all I have for you today. So hopefully that's exciting that it's short.
Any questions for Mr. Gray?
Thanks, Steve. You have a break since I left the audit committee.
Thank you, Mr. Graves. We will now take up agenda items 14, 20, and 23 in closed session. For the members of the public watching this meeting, I do not expect to act on other matters after returning from closed session before adjourning the meeting. We will now move into a closed session pursuant to Texas Government Code 551.076 to discuss the 2025 Texas Cybersecurity Framework Assessment. The Oversight Committee will also take up agenda items 14 and 23 while in closed session to seek advice from counsel pursuant to Texas Open Meetings Act 551.071. The following CPRIT staff shall join the Oversight Committee in the closed session: Ms. Doyle, Mr. Ellis, Mr. Burgess, Ms. McConnell, Mr. Somadina, and Menenke. I'm sorry, Soma, I totally messed that up. Mr. Jacob Parker and Ms. Shannon Cusick. The time is 11:49 a.m. Kristen, are we staying in here?
The time is 12:20 p.m. We will not take up standing agenda items 21 or 22. Turning to agenda item 24, the next Oversight Committee meeting is scheduled for February 18th, 2026. If there is no further business and there is no objection, the chair moves to adjourn this meeting. Is there a second?
Second.
All in favor say aye. Motion carries. The meeting stands adjourned at 12:21 p.m. Thank you.